a wonderful program. So we do hope that you're going to find new alliances, new partnerships, new ways of scaling how we are going to work together, and so that we can continue to deliver for the people of Kilifi. Having said that, allow me to brief you on a slight alteration on the program. We are going to go straight into the session keynote address. Our keynote speaker is already here, Dr. Noel Orata. Dr. Noel Orata is a consultant pathologist and is the immediate former chairperson of the Kenya Association of Clinical Pathologists. She is the ecosystem design lead at the Open Fences and a health strengthening specialist with a focus on laboratory systems based in Kenya. She holds a Master's of Medicine in Human Pathology and a Bachelor's degree of Medicine and Surgery from the University of Nairobi. She's currently a doctoral fellow at Strathmore Business School, where she's also the hub lead for the Center for Public-Private Conversations and Entrepreneurship and Innovation. And she's also the co-founder of the Pathology Network, a digital platform connecting institutions to specialized laboratory medicine services. And she's also a trustee and medical expert at Faraja Cancer Support Center and the immediate former chairperson of the Children's Sickle Cell Foundation. Dr. Noel Orata, we are quite privileged that you could join us this morning in this particular conference despite your busy schedule, and we want to welcome you to set the tone for us with a keynote address. Makofi tafadhali kwa daktari.
Good morning. Thank you so much. Welcome today. I think I want to start by thanking and observing all protocols. I see Bwana Waziri and all members of the Kilifi County Government, all community members of Kilifi County Government and scientific colleagues. Karibuni sana. I'll be taking us through a presentation. I'm waiting for it to come on, around universal health coverage in Africa. I think I do a lot of things. I must admit I'm not everywhere all the time, but I do work with amazing teams. That's something I learned from science. There's nothing you can do alone. You must be in teams. And so for today's presentation, I'll be talking about from discovery to delivery, strengthening Africa's scientific and innovation ecosystem to sustain universal health coverage, aligned to the theme of this third biennial scientific conference here in Kilifi County. Next slide. So why is science and innovation so important in this day and age? Kenya sits squarely, carrying the double burden. We've done a lot of work on infectious diseases, and because we're prolonging life now, we're now running into non-communicable diseases. These include the diabetes, hypertension, and cancer. Our UHC will potentially be at risk without evidence. I think one of the struggles we have is even as we get information from the global studies that are done, we're not contextualizing them to our circumstance. I remember I was at a conference in the UK and someone said, you know, for AI in Africa, you have to incorporate witchcraft as one of the reasons that our people sometimes would not go into the formal healthcare system to seek healthcare, right? So there's someone who's doing mathematical modeling and they're looking at how do we then embed our context-specific issues into science and innovation. We have, of course, opportunities. Africa has unprecedented potential. We have leapfrogged the industrial era and we're in the digital era. That's evident from M-Pesa, and I think we're doing a good job. And there are more phones than share uptake in this country. So there's an opportunity to take advantage of the digital landscape. And of course, Kenya's moment is that 27 million Kenyans are currently enrolled. This is information from October this year. And I think that's an opportunity to innovate, to finance, and to enhance service delivery. Next slide. So this is Kenya's universal health coverage at the moment. Of course, I've talked about the SHA. We have the free primary health care, which access is now a reality at level 2 and level 3 facilities. And then, of course, the digital linkage with a lot of health technology coming in. A lot of it is also brought in, again, contextualizing. I think we have a lot of situations where tech is brought into the country and a need is found for the tech as opposed to us knowing what our need is and requesting the tech. So we need to be clear on that. Next. So I got this from Kilifi County. I was afraid because Waziri is here and the internet hallucinates. But this is statistics around Kilifi County, looking at the population, very, very strong on vaccine coverage. Maternal health, I think there's a push towards going towards skilled delivery, which is good. And of course, the challenges that remain under 5 mortality, possibly also maternal mortality. Water and sanitation access are gaps that continue to persist. Next. And this is the amazing work and the amazing things we're looking forward to for Kilifi. There's been an enhanced community health promoter participation in terms of healthcare and intersection with the community. I think we underestimate the level 1 of healthcare. One of the things that Kenya used to always do, we used to focus on curative treatment, but what we have begun to understand is that preventive and promotive therapy and treatment is the most important. And actually by holding back and focusing on preventive and promotive treatment, you hold back 90% of patients in the community, and so you don't burden the facilities. And so the key 10% or 5% who are required there then have ample care with ample human resource who are available for them. We also have immunization workers, we have diagnostics, and we have biomedical waste, in which Kilifi is really growing and going in a big way. Africa's growing innovation potential, and this is where I think Kilifi and Kenya as a whole can tap into. So the potential is about $500 million, health tech funding in Africa. I sit squarely in that space through the pathology network. As a pathologist, I think maybe I need to demystify this. I used to do this as a chairperson a long time before I handed over. But as a pathologist, 1/5 of what we do is around post-mortem medicine. And this is important, supporting patients in closure, supporting colleagues in understanding causes of death, and many, many other reasons. However, 4/5 of what I do is all in the laboratory medicine, understanding how labs work. In Kenya, we are about 150 medical pathologists, specialists, and so we realized we're unable to distribute 150 people for 57 million Kenyans. So what we did is we took advantage of technology and used technology to manage these samples from the lab and take it to the pathologist. And so we have brought about access to a pathologist without even removing them from the government system. They require very high-tech laboratories. And so we are able to bring service. We've been able to connect. Actually, we have a Kenya-wide footprint serving Kenyans in pathology. We also have 4.02 billion, just go back to the previous slide, health research and development commitments tracked since 2020 in Africa. And Kenya is actually key in this research and development. And then we have 350 plus innovators, especially around supply chain technology across 27 African countries. Next. So where is the innovation funding going currently? About 80% is going to manufacturing investments. That takes dominance. We have about 1.75% in clinical trials. I think that's too little. There was a colleague, a pathologist, who did a study around hemoglobins. Hemoglobin is the molecule that carries oxygen. And he did an Africa-wide study, actually. It was for his PhD. The reference ranges on the machines that come from the other continents targeted for the Caucasian population shows that the normal reference range is between 10 to 13. It was very interesting to find out from his study that the normal reference range in the African population, because he picked samples from West, East, Central, Eastern, Northern, and Southern Africa, for Africans is actually 7 to 10. So if you use the reference range we're given by machines that come from out there, it means all Africans are anemic, which is actually not the case. So when I talk about contextualizing and doing our own data so that we get evidence-based decision making, we can then tell these manufacturing companies, we need you to adjust your reference ranges. Not all of us are anemic. Over 40% pilot phase funding. I have a problem with pilotitis. We do a lot of great work, but it weakens the system because once they pilot and they finish, they leave, right? So we need to think about how do we then go into sustainability? How do we keep this great work from the pilots remaining? And I think it's time for us as Africans, as Kenyans, as we colleagues from Kilifi, to always put into our proposals a sustainability plan so that we can roll over. I even know, like interesting drone companies that were here in Africa, they're charging in America now $150,000 per month. It's already out of reach for us, yet they piloted here in Kenya. So we must think through sustainability plans, and of course resulting in promising discoveries. Language and scale up of barriers remain as an inhibitor to this. So we have 3 shifts for sustainable universal health coverage. We need to move from projects to systems. How do we embed the work we're doing? So for example, KEMRI, I know KEMRI Kilifi is big. I see my friend here, Sophie, and they do a lot of work. How do we help the government plan around financing so that the good work you've done is now embedded into their cycles, putting it into the annual work plans and the county integrated development plans so that it's institutionalized and it stops being personalized to benefit the communities over a long period of time. Moving from pilots to scale, I've just talked about that, and of course, moving it from external support, looking at how do we now continuously support ourselves, prioritizing locally led agendas and county-driven priorities. So the most important in healthcare is human capital. Sometimes I worry about the many, many hospitals I'm seeing that are being opened as buildings, and we don't have human resource to work in them. Even in the scientific space, researchers are the most important. The people are the most important. So in terms of innovation and research, the researchers themselves come first. We have the data scientists, the community health workers and other healthcare workers in the formal healthcare system. And the most important is, what is the outcome of this work? We have universal health coverage at an Africa-wide level. 50% of the population in Africa, based on WHO, still lack access to essential health services. I think Africa has many burdens. We are a third world arena. Even Kenya, we call ourselves low to middle income, but I think to some extent we still have some low income challenges, and we need to look into that. We have vast terrains. We have, the sun works in our favors, but we also have vast deserts. How do we then take care of healthcare for a nomadic population? Chances are that's a problem that other continents do not have. We also have millions who have been pushed into catastrophic poverty by out-of-pocket expenditure annually. And this is significant because then you put someone into a dilemma. Do you choose to be healthy or do you choose to eat? It becomes fundamental, so we need to worry about that. Progress is real. Several countries have improved universal health coverage. I must give credit to Rwanda, South Africa. However, everybody needs to come along so that the whole of Africa is working together and we have interconnected collaborations and partnerships. And now the new threat, which is currently a big problem because we've managed to manage infectious diseases, is non-communicable diseases, climate change, and these shocks are eroding some of the RAMCA benefits, the reproductive, maternal, neonatal, and adolescent health benefits. Next. So what's Kenya's reform architecture? We have social health authority for financing. We have primary health care for service delivery, which is people-centered and integrated. In fact, I like the current primary health care because it's forward and backward. So it sends the person from the community into the hospital, but it also has a backward referral system, sending the patient back to the house. And then we have decentralization of tests. Counties design and own the implementation pathways for these healthcare reforms. So again, we have the young population in Kilifi, which is a bonus in terms of demographic and our current health reality. But it also comes with its own challenges. I think we've been seeing lately the HIV statistics, which are worrying. We also have encouraging gains from immunization, persistent gaps, including also undernutrition and adolescent pregnancies, and then geographic reality, which is the remote communities, high transport costs for movement to healthcare, which demands smart services and digital technology to support that. In Africa, we have 1% as the Africa Union target of research and development at the moment, less than 2% in clinical research and 80% on manufacturing. Next. But this is Africa's emerging innovation strength. Number one, we are young. I think I went to Amsterdam 2 years ago and I saw one child in a whole week. In 7 days, I only saw one child. One. I remember I couldn't get over it because in Africa, children are literally everywhere. And I think that's a strength we have. We have hubs and accelerators, which nurture solutions in medicine, telemedicine, logistics, diagnostics, and data. One of our biggest challenges is most innovations cluster around capital. They cluster around infrastructure. I think in Africa, we underestimate ourselves. Because, for example, in healthcare, if Kemri comes in to support Kilifi, that's a partnership. That's an innovation. You're changing the hospital there. Yeah, through simple solutions and not necessarily big ones. Even the fact that human resource is moved from the Kemri hub to move and work within the hospital, that's an innovation. The problem in Africa, we think innovation is always a tangible good. Innovation may be a change in process and systems. That's innovation. We also have $500 million in health tech funding raised by Africa Ventures, and it continues to be raised. I saw someone on the internet who said, Africa's solutions are based off of a need. And he actually said, as an African private equity investor, he does not take over the company at any stage. He actually allows the CEO to see the vision fully through, and he steps out of the company because he said the chances are the need was born out of, number one, money, but number two, to solve an actual need. Sometimes we have partners coming in who want to take over the company and the vision has not reached fruition, and then it falls apart. Another solution is connecting innovators to the county healthcare system to be able to show them how it would work integrated and even sustainably, and communities should be involved from day one, and this is one of our emerging strengths. So how do we make discovery to delivery concrete? We use surveillance data, qualitative and quantitative research, operational insights, and outbreak signals, especially in this era of pandemics and emerging diseases, to make decisions that are evidence-based. In development, we need to refine this into policies, protocols, tools, and products for real-world use. And delivery, we embed that in routine practice, sustained financing, and monitoring impact over time. Governance, ethics, and regulatory readiness. I think one of the key pillars that WHO doesn't have as a standalone is engagement. So we have, service delivery, we have all these building blocks, but to get those building blocks, you must be engaging. And I think that's the one thing we miss. And leadership and governance is the biggest pillar, in my opinion, in those building blocks. Research prioritization from the leadership with clear rules for ethics, data sharing, intellectual property, and community benefit. Ethical oversight, which strengthens ethics reviews, ensures community trust and participation. I've done a lot of work building ecosystems through open fences, and you'll be surprised to know people know what they need. A lot of people come with solutions to tell the communities what they think they need. They actually know what they need. And if you give them time, they'll even give you the solution they're looking for. And so then you're working your community becomes the champion for this work you're doing. Please involve the community. Digital and AI regulation keeps pace with innovation, ensures interoperability and data governance. We have these blockchains which are coming in a big way to make a difference. I think they're currently even being used in rolling out our loans for the banks. So it's a big deal. Let's take advantage of it because we're able to use it to even retrospect backwards and look at trends. Kenya has trends. We all know in June, July, it gets cold. Influenza goes up. There's one that has been going around. How can we stop gap this before the influenza breaks out? In Europe, coming from the UK, we had a long conversation with NHS. And in one of their primary care networks, what they do is they know that old people don't leave the houses during the cold season. So they've actually set up some team from their healthcare workers who go home to look for the old people. They check their blood pressure, give them the hypertensive medicine a month before the cold season kicks in. What has happened is it has reduced mortality by almost, I think, 45%, and of course, definitely morbidity. Fair benefit sharing, communities co-author research agenda, and see returns. And I think I must give Kilifi credit, Kenya credit for the community health promoter programs that we run, because I think this is now becoming more and more embedded. How are counties innovation nodes? Beyond implementers, they can be a test bed for approaches adaptable across Africa. So I call them sand beds, yeah? Sand pits. So you put the experiment into the county, you shake, shake, shake as you refine it until now you're able to send it out and you're able to scale it for different counties and become even a learning cornerstone for Africa. System learning, capturing data, comparing that, and feeding into higher level policy forums. I think in Kenya we have a lot of documents we have created that were created in a room and not from the actual ground up. So sometimes you find, because of that creation, it's hard to then implement because our realities were not contextualized and captured. Capacity building, training healthcare staff to engage with research and innovators. I love what Strathmore is doing, the institution I'm based in. A lot of the work we do is actually very community-based. We go out into industry and we ask them, will this work? The manufacturers tell you it's a lovely concept on paper, but it's impossible to achieve because we have capital issues. And so then you go back and you realize, okay, do we need to start this conversation from financing, realizing our realities? And the outcome is Kilifi will co-author Africa's scientific agenda, not just be a site for research. So a practical call to each constituency is required, and all stakeholders are important. Policymakers, researchers, innovators, and communities. I remember there's a public-private collaboration I did in Tharaka Nithi County. And a private lab was coming in to run the public sector lab. They were not taking it, they were just running it. But the perception in the community is, hospitali imeenda. It has become private. And I remember at that point, the community wanted to fail that public-private collaboration, which was to their benefit. At that point, Waziri had to come in and go on radio to shed that perception. But what did it do? The county had stockouts, the usual limited resource challenges. They only could run 27 tests. After doing damage control and the community understanding, today they do up to 4,000 tests. Everything is acceptable, including molecular and chromosomal analysis for colleagues. So it's a worthy investment to be patient. Next. So public-private partnerships is another way to grow universal health coverage. WHO made a resolution and aligned with PPPs. IFC, flagship models, the World Bank. ODA, the official development assistance, demands local capital. So now there's co-financing from us, the local people. Nobody will be giving us money. We have officially moved from aid to trade. Everyone invests. And of course, risk sharing essentials, leading to efficiency, quality, and sustainability. What are the 4 pillars? Health financing, service delivery, input and resources, governance and accountability. Again, around the WHO building blocks, but at the center of it is leadership and governance. Manufacturing and technology, transfer via PPPs. I know that Kenya is in the process of putting up biovacs for our own vaccine supplies. This came as a shock from COVID. It's not always a bad thing. Sometimes you have to go through turbulence to learn. 60% is what the African Union is targeting, that Africa is able to make vaccines for 60% of its own population. WHO IFC, a partnership with local health product manufacturing and development finance institutions, accelerating capacity expansion, including Africa Development Bank. Building institutional capacity for public-private partnerships. I have a bias because this is my interest in my PhD. How do you grow sustainability in Africa? Not only through financing, but through other partnerships and collaborations. Even as we go into these partnerships, governments don't always have to put money. They can put in-kind considerations into these partnerships. They already have the hospitals, the infrastructure, they have the human resource, so then the other partners can come in with the rest. So strengthening our PPP units at the Ministry of Health, transparent and accountability mechanisms, robust accreditation systems, and policy clarity on the same. The new collaboration architecture for Africa Union is the Global Fund, MOU. We have the domestic resource mobilization in Africa, digital and community integration and innovations, and then Africa Health Strategy 2030, whose key pillar is self-reliance and resilience through multi-sectoral engagement. That's it. Yes, so these are the potential opportunities for Kilifi: diagnostics and lab networks, digital health infrastructure and development leading to innovation, and integration of electronic health records, surveillance platforms, and telemedicine, supply chain innovation, and human capital. We also have, we can jump that to the next slide. Yes, from data to decisions, how do we close the gap? So problems in research is that the research findings rarely reach county budgets or clinical guidelines. Kilifi's success. Okay. Sorry, I'm observing protocols. So Kilifi's success is based off of the current vaccination, 90% penetration, and maternal health gains, which show science-informed programs work. The next frontier is applying the same rigor to chronic diseases, maternal health, climate-sensitive conditions, and the mechanisms are science policy interfaces and budgets for implementation research. So how can we make Kilifi a living laboratory for universal health coverage? The sandbox that I was talking about. Is the ecosystem ready? Are the county teams, universities, institutes, and partners aligned? The data sources, are they available for surveillance, linked to DHS, WASH, food security, operational research, and do they all converge? What are the opportunities moving from a reactive approach to a proactive approach? Looking at what seasons are coming in, how do we handle it before it devastates us? Anticipating and protecting the vulnerable populations, and ensuring every insight has a pathway into policy, practice, and products. 3 concrete actions that we can take away from today. Are we aligning our research agenda with Kilifi's own UHC data gaps and county priorities? How do we strengthen platforms linking scientists, policymakers, and community representatives? And how do we invest in county budgets, in pilots designed for scale and not publication only, so that it becomes sustainable? One county turning science into full life cycles is Kilifi, turning innovation into inclusion and evidence into everyday access to care, contributing to a continental story where African science and African leadership are central to health for all. Finally, a continent that is ready, a county that is leading, and a future that is possible, from discovery to delivery. Asante sana.
A bigger clap for Daktari. And I would kindly just ask you to join me back here as I invite Dr. Diana Wangari Gitau to bring in the high-level panel as we discuss more on sustaining UHC at subnational levels. But before that, I'm reminded that Livingstone Bora, where are you? Livingstone, yes. I'm reminded that you had prayers for us. And I do not want you to go back with them. And I want to continue any further. Please come here and pray for us, even as we look forward to going to the official opening of the ceremony.
Thank you. Let us bow down and pray and commit this session unto our good Lord. Let us pray. Dear Heavenly Father, in the precious name of our Lord Jesus Christ, we want to come before your presence this morning, especially for the grace and mercies that have bestowed upon our life for this third annual conference. And to you do we commit it, O Father. We thank you for all circumstances that have enabled this to be possible. We appreciated the governance of this county, our dear governor, who has given it a blessing. We thank you for the leadership of the Department of Health, for all who have given unto it to participate, to be sponsors, and to be partners. Dear Lord, we thank you and commit these sessions unto you, that by your grace you shall be able to hold our hands from the beginning to the conclusion of every session. In the mighty name of Jesus, we do pray and believe. Amen.
Thank you very much. It would have been a bit dangerous to walk away with such powerful prayers. I'm going to invite Dr. Diana Wangari Gitau from the Nation Media Group Foundation to please welcome your panel, and you're going to also ask the keynote speaker some few questions.
Thank you. Okay. The keynote speaker reminded us that it's well and good to talk about universal health coverage from national frameworks, but in real sense, it's about the implementation, right? We can all sit in rooms, we can all discuss and come up with good scientific papers, we can all come up with policies, but when you come to the ground, as they say, mambo wa tofauti, right? So this panel is about that. It's about talking about practical solutions. What's the lived experience, right? And I'd want to invite my panelists to the stage. I want to start off with protocols observed. I'd like to welcome our host, right? The Kilifi County Government, the CC of Health, Peter Karibu. Thank you. Santi, this is your seat. Santi. I'd also want to welcome Professor Benjamin Sofa, Senior Principal Research Scientist, KEMRI, Karibu. Our keynote is already seated, so Karibu tena. I'd want to welcome the County Director, Helen Keller, Peter Ofware, if he's here. Yes, thank you. Professor Malin, Aga Khan University, Karibu. And finally, Professor Halimu Shauri. And then I'll thank you. Asante. Even before we go to the questions, we must congratulate Kilifi County, yeah? Because above all else, as we say, things are practical, yeah? We often sit in silos, right, as scientists, never communicating to each other. I like what the keynote address mentioned, that it's about engagement. We can have systems, we can have governance, service delivery, but if you're not engaging, yeah, there's no actionable step, right? So I'll welcome everyone to the panel, and we'll get going, right? I think I'll start off with our host, as always, yeah? I'll start off with the host, because what Kilifi County has shown us is that implementation of universal health coverage is not about just the technical aspects, right? It's about the relationship, the goodwill, the partnerships. So my question to you would be, as Kilifi County, what are examples of partnerships? What's the role of partners in the county in terms of implementation of UHC?
Thank you very much. First of all, would like to appreciate the partnership, the great partnerships we've had and we've nurtured in this county over the years. In this county, what you're saying, what is the role of the partnership? This is really one place where we can say we've really, forged the agenda for health, universal healthcare in Kilifi together. We sit with the partners and we prioritize based on what the data is telling us. Some of this information is generated by the partners. Some of it is generated from our own service delivery. So it is a very collaborative process. So we see the partners complementing the efforts of what the county is. And we see this partnership as all of us, aiming at one goal. And we have set up a forum where, the partners sit together quarterly. We look at our data and then we plan to address the challenges and issues that we have. So in terms of what is the role, we see the role of partners being complementary to the work and the activities that the county government is implementing. Part of it is coming to finance the activities. Some of it is coming to provide technical assistance. Some of it is coming to provide the data through research. And some of it is coming through implementation in the field. We have quite a number of partners who are implementing activities in the field. Thank you.
Thank you, Bwana Waziri. I want to go to one such partner that you've mentioned, because we know partnerships are not equal. Some of them strengthen, some of them create dependencies. They're very different levels, right? And we have just said we're moving from aid to trade. So Peter, I'll be going to you. From your cross-country experience, being in Helen Keller, what differentiates counties that use partnerships strategically from those that become dependent?
Thank you very much. First and foremost, I would like to thank Kilifi County for allowing us as Helen Keller to work in this county and having a great partnership and also inviting us to be part of the panel. What I would like to say, what we have observed in 7 counties where we work, we have seen a very clear distinction of those counties that emphasize partnership and those that unintentionally create dependency. So what we have seen in Kilifi is quite different, because Kilifi has a very strong partnership management, coordination, and planning. And what is important that we need to understand is that all partners need to be brought together. During the planning, the partners need to be part of CIDP and health sector plans. We need to plan together. We need to ensure that our partners' activities are included in the budgets. We need to ensure that there is coordination and regular meetings that are well coordinated by the counties. And most important is that Kilifi has done all this compared to other counties, because what we see if partners work in silos, it creates what people work in parallel, they work in silos, and therefore the duplication of efforts, which for me, the resources are scattered instead of being centralized and managed to provide support to the people who need it. And therefore, we as Helen Keller, we see our work strengthened by working with county structures, ensuring that our county staff are involved in the work that we do, but also emphasizing the need to collaborate more so with the counties for sustainability. Thank you.
Thank you. I mean, as you said, it starts with bringing everyone to the table. But I think Waziri here mentioned that it starts with data so that it guides the agenda, right? And I'll be coming to you, Prof. Benjamin, because counties generate a lot of data. I mean, we're in this room because there's data. We're going to be seeing a lot of posters outside, right? You're sitting with scientists, researchers, and implementers as well, right? But somehow, many people would say counties and implementation is sometimes not driven by data, right? It's not evidence based, right? So the question is, what systemic shifts will strengthen evidence-informed governance?
Thank you, Diana, for that very, very broad and elaborate question. Let me start in the event that you snatch off the microphone from me, because I love talking. And let me start from the end with a few take-homes from in answering your question. One is the question around data and information news. I think really, really important to understand, because this conversation happens in many, many forums. I think what's really, really important for us to appreciate that in health and health system organization and functioning, data is beyond numbers. Data is all the processes and mechanics of information gathering that help us to inform decision making. It can be observations, it can be experiences, and it can be learnings through observation and conversation within. So the reason I'm saying that is the practitioners and managers on a day-to-day generate a lot of learning in doing, and that information is really, really important when it comes to stewarding and steering where the sector or the system moves. So that's an important point I wanted to say. Then the second point I wanted to make also kind of take home is counties, not just Kilifi, across the country, and have actually pretty much now developed pretty strong, healthy data and information gathering and review systems. If you talk through a lot of counties, because there's a lot of widespread adoption of digitization, the widely used DHIS2, a lot of AMRs being used, and a lot of data information gathering systems have been embedded a lot. You'll find in many, many settings a lot of information, forums, and data review systems regularly being held at facility level, sub-county level, and counties. What we lack, back to your question, I wanted to start from so that in case you start your moment. What we've lacked is a bit of de-link between what we are learning from that rich information to actual actionable decision, especially where resource allocation is concerned. So we've seen a lot of challenges in allocating our resources, prioritize around what we are learning from the range of information. And this has been both because of structural challenges, but also a lot of them are really systemic challenges. Some of the structural challenges, like for example, the systems and mechanics, for example, for performance monitoring, technical performance monitoring, and within the department, for example, your annual work plan monitoring or at facility level or sub-county, are delinked from the budget making process. So you have your regular quarterly meeting, review meetings, practitioners sit together, understand what's going on, identify what are the challenges, but you have a completely different set of players who actually prepare the budgets, and they don't talk to each other. There's a complete de-link there. The other thing is to try to strengthen that. We've seen also in terms of building structures in counties, Kilifi is one of those, some emergence of what we are calling research units. So you find a county research unit or county research division. Part of the challenge has been that a lot of those have gone into focusing, playing a lot of role in their governance or on oversight of research activities happening in that county, rather than actually the core, which should be the knowledge translation. So working with the people who actually do research or information gathering to actually translate and implement or learn from what information is coming from those people. So basically just emphasizing on the role and the need for our county structures to focus on what both is core, but also what they have better capacity to do, rather than actually doing the research itself. My last point really is the call is really to try to be very intentional, and there's lots of activities going on, but we really need to be very intentional to bridge the silos between the data producers or the information producers, including our practitioners, and the budget making process. And that is going to take a lot of high-level political will, both within Department of Health, but also actually with colleagues in Department of Treasury, because there's a lot of influence with colleagues in Department of Treasury on how resources are allocated, which really quite a lot of time frustrates our colleagues in health. Thanks.
Thank you for that. I'd want to remind my coffee. I'd want to remind the audience that we will take a few questions. It's not us talking to you. We'll take a few questions, just this one round. Maybe a few comments from the panelists, then we take any questions that you have to the panelists, right? Keynote. Dr. Noella. Something that Prof has just touched on here is the communication between both the county health teams, different units, and budget, right? You sit on the private sector arm of that. You talk about capital. You talked about 500 million, right, in health tech funding, right? And a big part of this, I think what Prof was also hinting at, is that sustainability becomes key, and if you don't have financing, it's a challenge, right? So my question to you, and given this is a practical panel, right? UHC sustainability, it relies on functioning markets and private sector engagement. Are there county level models that have succeeded or struggled in this, in driving UHC through private sector engagement? What models work?
So I think the models that work best is the one that has correct stakeholders at the table from the beginning. I think we don't have strong enough governance frameworks on paper and actualized. And so you find, for example, the one that I was very involved in, when they were starting the project, they had the lab people who came in and the healthcare workers. They forgot that there's a legal component, there's a financial component, there's, they needed to get education and all these other sectors involved. And so what happens, they didn't have the communications team from the county. So what happens is then they run into this dilemma where they are then doing damage control at every step. So my thing is, do we have the correct governance frameworks? And even when we talk about governance frameworks, has anyone told us what step one is? I think in Kenya we have a lot of fantastic documents, but nobody tells you how to get through to the end. Somebody needs to sit you down and say the correct stakeholders for the first conversation are A, B, C, and D. And so I think there are models that have worked. NHIF is a good one. It was a collaboration between the public sector and the private sector was also a beneficiary of NHIF. But they were very clear how it worked. It was clear, there was clear mechanisms for claims, there was clear mechanisms for challenges. The payment was open, it was known. So there are models that have worked. However, I think the integration of these stakeholders, because not all are required at every stage. Some are just for information purposes, some are truly the decision makers. And like Prof said, the politicians are also key, because you need to have a lot of goodwill to get this to work. So I believe the stakeholders are key.
I don't want the mic to move from you because we have a follow-up question before we come to Prof. Malin. Just a follow-up question. Because the question is, how can then counties unlock this capital without compromising equity, We talked about the element that it has to come from the ground up. There has to be community ownership, right? How then do you unlock the capital without compromising on equity?
I think we need to start formulating our contracts so that it's outcome-based and not input-based. I think a lot of us develop contracts where it's how many syringes did you buy, how many, but we're not looking at did the patient actually get the outcome we wanted, right? And so we don't look at morbidity and mortality, and whereas in healthcare it's there. And in fact, there are actually financial instruments which we can unlock using that type of contracting. You can go into social impact bonds and development impact bonds where you are paid, you're given money as a loan, and if you achieve the outcomes that you have agreed on, it's actually switched to a grant. And so it stops being a burden to the county. So I think there's that type of blended financing we can go into, and then blended subsidies and user fees also can be arranged. I think for a long time in this country, we have talked of free healthcare. There's nothing free about healthcare. It has never been and will never be. What has happened is that all these vaccines that we claim are free and ARVs that we claim are free are actually, that burden is shouldered by the taxpayer and paid for by the government of Kenya. If the users of this service begin to understand that it's to my benefit, and so I should put in a little something because I am a beneficiary of this payment that government is making, you'll find that they're more cautious and less careless about how it's used. And so they become more strategic around planning. Healthcare is better leveraged. You find that you'll get, for example, a discount if you come in for your annual checkups for non-communicable diseases. That way we are doing more promotive and preventive medicine as opposed to going into curative, saving on costs for the long term. So there are many mechanisms. I think that's just a few.
Thank you. I'd want us to shift gear to Prof. Malin here, talk about, again, a model, but with a particular focus on maternal child health, right? So from your vantage point, what must counties prioritize to reduce preventable maternal, neonatal, and adolescent deaths? And we also have a follow-up question. We can start with that, then get to the second point of the question.
Thank you so much, and a good morning to everyone. My plenary lecture is actually on reducing exactly that. So I don't want to anticipate too much on that because you will hear during 20 minutes me speaking about that topic. But maybe I can, if you don't mind, add a bit because I'm the co-chair of the Kilifi County Health Stakeholders Forum. And I've worked in other counties and I know the mechanism of it, but I must say Kilifi County is one of the best. And why? Because what does it mean, a Kilifi, a county health stakeholders forum? We bring together all the partners, the stakeholders who are in a county, working in the sector of health. Of course, led by the Department of Health, led by Waziri, led by the leadership of the department. And then our role is for the partners, there is one kind of delegation of the partners, one who is chosen. And the honor is for me that this time to lead together with the government and the partners, the Kilifi County Health Stakeholders Forum. Now, how many are we? It's a big question. We looked at it, and of course partners come and go. Sometimes they start projects unannounced that the government is maybe aware of or not formally aware of. So what we have tried to do in these last years is really make it formal. Who is a partner? What is this partner doing? Be it an NGO, a private, public, academic, doesn't matter, but who are the partners in this county, number one. Number two, what are they doing? Because as it happens everywhere in the world, you can have a country or a county where maybe, 10 partners are working on maternal health or on infectious diseases or something without knowing what the other one is doing. And a lot of pilot projects are started. Pilot means you pilot, then you disappear. And we are all, we have enough of pilotitis. How can we make what partners are doing really part and parcel of the government policy, and who sets the priorities? That should be very clear. Should be, and it is. In this forum, it is the county government who sets the priorities. So if maternal health is a priority, then partners are invited to work around that topic to give it priority. So we are now about, Waziri can correct me, I think when we started maybe 80 partners, but not clear who is doing what. So we have tried to harmonize it a bit. I think we are with 30 major partners. And they are called together, led by Waziri, led by the department. And we as partners, we meet once every quarter. So then we have 6 technical working groups on these topics. Infections, RAMCA, health systems, finance. These 6 technical working groups, they have a chair from the county, and they have one of the partners co-chairing. So they bring their findings, and their reports so that everyone is aware and that we don't duplicate too much. If a new partner comes in with menstrual health, please make sure that you know there are already 3 groups, 4 groups working on that, and that we coordinate. And I think that has really, thanks to the leadership of the county, that has improved a lot, but more needs to be done. Because we still work a bit, we come with our own agendas as partners from everywhere. We try to do our own thing, but we really need, I think for me, county leadership is key. It's the county who should decide what are our priorities and inviting partners to tick the boxes, to help them to reach these priorities, not the other way around. So we have these 6 technical working groups, and I think the achievements of the last year is really that we don't come the 6 working groups and just saying 1, 2, 3, 4, but that we ask the county government, tell us for this year, what are your top 3 priorities? What should we, as partners, stakeholders, what should we focus on? So I think that's the way to kind of summarize. Waziri can come in, but how the Kilifi County Health Stakeholders Forum is functioning and how we as partners are happy to contribute.
It's such a valid point that then we're moving away, and again, Kilifi County being a very good example from, as you're saying, we're communicating to each other. We have moved from 80 to 30. There's visibility every quarter. These are the projects, there's communication. The question many people would ask again, back to the keynote around from the ground up, where does the community fit in this process?
I think the community is very well represented in this project. All the government, the county government and the partners, they work with community advisory groups, with CBAs, NGOs, CBOs. So it's really the community, because it's not top up that we are saying this is now priority. And the government is very well aware of what are the major health problems. I will tell you, years ago when we started this forum, that was 2017. So you had the research community in Kilifi, very strong, Cambry and others, and you have the government. So we were asking, at that time, 2017, what are the priorities for the government in the health sector? Please write your top 10. Then, blinded, asking the health community, the research community, what are your 10 research topics you are working on? Is there any alignment? The first thing was they didn't know each other, like very little communication. A lot has changed. But the number 1 at that time, priority, was road accidents. Not one research group was working in that area. Of course, there were alignments. There is HIV, maternal health, malaria. Some of the factors, they knew each other. But so what has happened in the many years is that there is really an improvement on knowing each other, knowing where to get the data, knowing how to use the data, and working together towards one goal.
Okay, thank you, Prof. Marlene. I think, as you said, it's inclusive, and I'll be turning to the audience for questions after this. Want to hear from Pwani University. Academic institutions are always a mesh point of ideas. What would you say is the opportunity for innovation from where you stand, right, around implementation for UHC coverage? And I'd want you to focus on community solutions, right? From the university perspective, what's the opportunity for innovation?
Thank you very much. From the university perspective, I think the opportunity is big. It's big because as a university, we try to cover so many areas that infuse into the whole spectrum of healthcare. We are more into not only doing research that feeds into the research ecosystem for medical services, medical care, community care, but we also contribute in terms of the trainings that we give to students At Pwan University, for example, we train nursing. We have nursing students who go back into the community supporting healthcare workforce. We train medical students. They are there, public health, food nutrition and dietetics. So in our view of health and health coverage, we are much more not only in healthcare financing, which is about healthcare coverage, but we are bigger than that. And from the keynote speech, I think it was very clear that the greatest win for this struggle for healthcare will not be in healthcare financing, but in health promotion and prevention. Probably if I ask the audience how many of them have woken up in the morning and had a run or a walk, well, only one, you can see. So you cannot win it by waiting to get sick so that you can have health coverage. You must prevent that sickness. So we should not wait till we get sick. I think the next conversation should be, how can the county contribute to us not getting sick? I don't want to be sick so that I can look for SHA. Thank you.
Absolutely. Thank you. I want to turn to the audience. Yes, Bwana Waziri.
Just wanted to react on before you turn to the audience, on the issue of where the community participates. I think one of the things that has happened, I think, in the last few years is there's been a lot of what we call civic engagement through various processes in the county, through our planning. Our work plan never goes through without public participation. So we walk through the communities in this. Again, there are quite a number of civil society groups working in the communities. It's amazing the number of memorandums I get in the office about health issues that are coming from the communities that are informing our planning. So there's a lot of community engagement in the process. But I also want to mention the other issue about private sector engagement. I think one of the challenges we have is expectations from the public engagement is that the private sector is not very patient with the bureaucratic systems in government in decision making. And I get a lot of that flack when they say, we want this signed tomorrow. It is, so there's that understanding, the sectors understanding one another is a challenge.
Thank you. Yes.
I think we as a university also have open medical forums. Like 3 weeks ago, we had a medical camp and we attended to around 5,000 patients across all disease spectrum. So we also open our gates for the community to come and benefit from the services.
Okay. Protocols again. We'll be welcoming, I believe, the governor to come in. So we'll pause the panel as we welcome him. Yeah. Thank you so much. I think we have the right man in the room for the audience questions, the burning questions. I think we really do want to hear from the audience, not just for the panelists, because again, for us to be seated, it's because Kilifi is a model. We've heard from all the panelists, right? There's goodwill. There are partnerships that are working. There's community involvement and community ownership, right? But it's one thing to say when we're seated on stage, it's another to hear from you. So if you have comments, feedback, or a question, we do welcome you. We have the Honorable Governor, we have public sector, private sector represented here. What would you want to see? What have you been hearing? Or if you have a direct question. Anyone with a question? There's one corner. I will to you. There's other.
Thank you to the panelists for your a lot of wisdom that you have spoken.
And your name's
okay.
Introduction, Daktari.
My name is Nancy Kagwanja. I'm based at the Kemri Kilifi, and I just want to thank the panelists and the keynote speaker for the, for their talk and for all of the wonderful wisdom they had. I have a question regarding something that Noel mentioned, but that is not to put you on the spot. Anyone can answer, including Sofa and Peter, concern innovations around raising capital. I think you talked about bonds that are converted later into grants and so on. And I'm wondering about what the experience has been with counties engaging kind of innovation for financing, and what support has been available from the national government for counties to engage directly with those forms of innovations. Thank you.
Okay, you can pass with sir. Two questions first. Okay.
My name is Patrick Oyaro. I work for LVCT Health, USAID Stawisha Pwani. And thank you for the presentation and the panel. My question goes to the academia representing the universities. How are we ensuring that the school projects that the students are doing speak to the situations or the issues that are in the county? To what extent do we collaborate with the Department of Health, for example, so that those projects can be meaningful and contribute to the improved outcomes of the people that we serve? But then also, I can give myself an example that I trained as a doctor, but I was never told about procurement and commodities, and I was never told about AIE. And as soon as I came in, I was supposed to have a CT, and then straight I came with something for me to sign. I didn't know what to sign. But the question is, how can we integrate some of these things to the students before they graduate? The last year of their graduation, we introduce these things so that when they come out there, they already know them. Thank you.
Okay, thank you. Let's take those two first. There's a question on private capital.
Yeah, so all protocols observed. Yes, blended financing has not taken shape in this country simply because it's very difficult to structure. Healthcare is very interconnected, extremely complex. How do I quantify Prosofa's contribution? It's just as simple as that. How do I quantify so that he is covered under the county arrangement with this high net worth individual who wants to then put in blended financing? So part of what I'm doing, in fact, for my PhD is actually that, looking into how do you structure healthcare, public-private partnerships, blended financing and other financing instruments so that the risk is shared equally between the public sector and private sector. So to be honest, none has taken shape. The one that kind of went to fruition was Queen Mamohato Hospital in Lesotho, which failed miserably because they didn't cater for the variances in the development of the infrastructure. The dollar at the time was also misbehaving. That wasn't planned for. So going about PPP projects are a very mega time-consuming process. National government is very supportive. Through Open Fences, where we focus on public-private collaborations, we're working closely with Ministry of Treasury, the National Treasury, to figure out how to tailor these instruments and these financing mechanisms for the healthcare sector. Because sometimes in healthcare, in fact, a lot of our capital is not for things. It's predominantly for people. So how do you then structure that? So to be honest, there's been none that has actually taken shape. I'm almost defending my proposal, so I've been reading actively. So I know there's none actually that has happened, but I feel that that will be an offshoot of the work I do. So I'm really looking forward to that because sustainability at the end of the day is what we're looking for. Thank you.
You might be looking for grad students to help you this at this
Absolutely.
rate, yeah?
And I just wanted to contribute to his conversation. So I've done an MBA as well, and I think it's very useful. And I also am the head of department at a medical school. So I absolutely agree with him. It's something that needs to be integrated, perhaps as the education ministry, because, in healthcare we sit in all sectors. I mean, for me, myself, we even go to court as doctors. So I would suggest that if it's high time we figure out what universities are good at doing in MBAs like Strathmore, and figure out, can we co-develop a finance module that can be done in the final year? Because at the end of the day, it's a benefit to the individual, it's a benefit to the institution, it's a benefit to the country. So that we are already developing managers before they even step into the management role. Thank you.
Prof. Malin?
Thank you very much. I think you are talking about localization of training, and especially medical training, and whether medical practitioners can be able to do other duties. I think we have to be very particular in terms of, one, the curricula are different for different professionals. If you chose to do medicine, you will be good and excellent in medicine, but not in procurement. You want to be good in medicine, and then you are good in procurement, you are good in communication, then others will lack somewhere to also contribute. It will defeat the same purpose of this inclusive kind of conversation that we have. But I get your point. Everybody normally has that kind of a feeling. But the structure of training normally is for professionals to know more and more of less and less of that profession. Managers are the ones now who are supposed to know less and less of everything. So you can't be both. You have to choose. But we try in terms of integration. We really try. We try in terms of, attachments. We take you to attachments so that you can see how others are requisitioning needles and syringes. You can be able to see and learn on practice. Field trips, we take you for field trips. We also take you for internship so that you can be there for a longer period of time to learn what others are doing, how to write a memo. Even doctors, they are difficult because they are in English. They are only to show very interesting handwriting that we can't read.
Thank you so much. You can all be everything. There's one final question as I list to pair one center. Do you want in 2026 done differently? Questions? There's a question? Yes.
Sorry, my name is Francis Toya. I come from Point University. I'm a student, and we were discussing this thing came by heart with critical. I think health cuts to everybody, including animals. So it needs to be tackled, as Prof was trying to say, prevent and kind of these things. But again, doing research is also exciting to us as students. Right now, I have a project. I'm very much interested in health issues. I'm a sociologist by profession, but I've built up a project in the last year to make sure taking the to call now especially that it is. So how do you help us to do this? Because expert is their way to students to make sure that they are doing the critical skill.
Thank you for that. I think that question will be addressed in one of the remarks. I will sign Prof. Benjamin. You'll address that as you guys in remarks. What you want to see? Address that question.
It's very really and thank you for moderating the organizer for here. There's a lot to say for the question of expertise. Really, for me, my call from put into mind is really a key point. Interest was really what I would move forward is taking health beyond policies. And this is really, really important in both in framing but decision making and the choice of investment, is because medical services like in hospital like garages, and you only go to a garage when your vehicle has broken down. And I don't think we are only for vehicles, bodies to break up. We only want those. So this means the community need to risk about focus on strengthening, preventing from the garages, which we put then shifting a bit of the model of even resource allocation prioritization, investing more on prevention and study less into your kind of high. And that's why sometimes we do focus on medical. Medicals are very personal. When has a stage 4 cancer, it's very personal to me and immediate family and have very, very devastating effects. But actually, a small intervention, say, as improving the ongoing HPV vaccination to our teenage girls will prevent that big catastrophe to that individual. So I think moving forward, we want to see more and more invest more. The resources are unlimited. And we'll be able to continue with the physical food. So get value money, we need to think in at community level. What to see is being able to fund the dishes through both facilitating and empowering, or practitioners provide city manager county and this county give capacity to make this including of resources because additional issues actually life as thing. One have them until them see them. I don't agree more. I think I'll end my talk with a quote. Use this on many forums. It's associated to one of the governors in Nigeria. And it's been very famous, it's gone very well. He says, health is too important to be left to medical practitioners alone. Health is the business of everyone. It's not the business of doctors and practitioners. So I agree with you. Health is the business of everyone. Our quest to leave no one behind, we involve and engage everyone because everyone has a role to play in us being. Thank you.
Thank you. Peter, any call to action remarks?
My call to action actually is when we are looking at health, we need to look at the behavioral aspects. Health-seeking behavior for people. The attitude, I think the decision to seek health is very important, and that is why health-seeking behavior becomes very important when we are looking at the matters. It is not just medical, but many aspects to a healthy being, physical, social, and all cultural issues that are intertwined in health. For my action is professionalization of CHVs and stabilizing their stipend. For example, many years back I started the National Community Strategy Technical Working Group, and these are issues that are discussed for years. Paying of stipend to CHVs is not stable. The other thing that we need to see is strengthen CHV facility linkages. That is very important. It is the community health strategy book that needs to be followed. And finally, something else that we need to see happen is that we need to activate community structures. We talked about there's something called village committees, which sometimes are not functional. And this need to be structured so that we can have structured dialogue at community level led by community health volunteers. Sorry, that name has been changing for many years. Community health workers, community health whatever. Now we are talking about community volunteers. Promoters. So from volunteer to promoters, probably again some years to come it will change to something, I don't know what. But finally, we as Helen Keller, my call is that the county government that now Your Excellency, you are here, you continue strengthening the partnerships and coordination at the county level to ensure that meetings are predictable and partners can work together as a team to ensure that we are leveraging our resources together with the county resources to ensure that communities and mainly children and women get the services that they need. Thank you.
Thank you. Dr. Noel?
Yeah. When I think
Comments
about
fupi.
Yes. When I think of three words. I think of healthcare ecosystem approach. I think one of the things we have not done very well is the multi-sectoral coordination and working arrangements. National to county, county to other counties within the county itself. So how do we promote this? Because I think about, for example, adolescent pregnancy. Is the medication involved in this conversation? Because by the time they're pregnant, they are the healthcare burdens. The healthcare system then handles that. But how do we reintegrate them into the education system so that they don't continue to have children at a young who will also be covered with the system? How brought in the correct other sectors to support this work? Now, two things about sustainability. The Lloyd is talking about. I think Kenya we have done sandbox, we can do the work, we have equal latency in charge of projects. And now talk about sustainability. We make project sustainability, looking at funds, human resource, capital, tech standards. And finally, through very supportive leadership and governance, through structured frameworks, depersonalize this work and institutionalizing it for posterity. And that way then we frame and push forward our healthcare system.
Thank you so much.
Just to stay in line with what colleagues were saying, I think health is in the home and disease is in the hospital. But we have to call for more investment in prevention, what our colleague was saying. But we have done a lot in prevention. Then you screen for cervix cancer, but then there is no way to go for treatment. You screen for syphilis, but there is no treatment. So I think we cannot just say we do A or B. We have to make sure that there is a lot of investment in prevention, in good health and so on, but also the facilities and the health systems have to grow along the same way. Number two, like I said already, I think the leadership, the governance of by the government is so important. The health sector, and we should embrace them, but make sure how do they really contribute, because many of us have not been raised with this technology. So the young generation will help us to integrate this. But we also have to look at what are the dangers. Because we see, I just, was told from UN agencies that Kenya is the number one in young girls presenting themselves through media for sex work. So I mean, Nigeria, Kenya, this is kind of, how do we handle this? What do we do with this? And then the last one, I think, I'm not sure how many in the audience are below 25. Here, maybe you raise your stand. But
Have a few at the front.
But in Kenya, youth is defined up to 35. So maybe 35. Stand. Raise your hands. there are not that many. So we talk about a country and a county with a lot of young people, and we talk about this symposium. So we should do our very best to involve, to include also in the stakeholders forum and wherever we are, to really have the voices of the young people, because we miss them here.
Thank you so much. Coffee.
Thank you very much. Mine are also very brief. One goes to Waziri. I know he's not there, so I have the privilege. Of Waziri, 2026, I want you to call us to discuss about why we should not get sick, so that we don't talk of universal health coverage. I think nobody here wants to be sick. Who wants to be sick here? No one wants to be sick. Why are you discussing universal health coverage? We're already sick. My number one. My number two, we expand the definition of health. The definition of health has expanded. We are still silo. We are still, narrow. Just focusing on what we call sciences. Open it up. Spirituality is medicine. You have to hold the Bible, you have to pray so that you can have spiritual peace. Social well-being is part of it. Mental health is part of it. We should not be sick and start, pressure. Rising governor to provide these facilities. We need even the facilities to go down. We don't need more hospitals. We need more physical facilities to do exercise. We need more food. We need water so that we don't get sick. Me, I don't want to get sick. You guys want to get sick? Me, I don't want to get sick. Finally, sustainability will only be sustainable in health when we do prevention, when we do promotion, not curative. Curative is very expensive. That's why we are struggling with the SHA, with the billions of money that could be invested in increasing the well-being and welfare of the people. But now we have to use it to provide drugs and to provide medical facilities, medical equipment. We can reduce this. It is a decision we have to make in 2026. It is a mindset change that we have to make. You have to wake up very early in the morning, hold your Bible or Quran, read, pray. You have to exercise after that. You have to dance to music for emotional health. How many people danced yesterday? Nobody. So only one. Now you say only two. Thank you very much.
Thank you so much. And thank you for the panelists, Makofi Kwao. Before you get up, there'll be a group photo, but a comment just also to Your Excellency. I think from what you've heard from the panelists, each one of them as they started, they said Kilifi County is a role model for other counties. And we want to say congratulations to you and your team and to all of you as well. And if you'll join us for a group photo and Bwana Waziri pia.
Thank you very much. A big hand to the wonderful panel. Mr. Peter, Helen Keller, Asante Sana, Dr. Noel Orata, our keynote speaker. Thank you very much. Professor Benjamin Sofa from Kemri, thank you very much. Professor Malin Tamaman, our chairperson of the Kilifi County Stakeholders Forum, Asante. Professor Ali Mushauri and my good friend, the Deputy Vice Chancellor. As a bigger hand to Dr. Diana for taking us through that particular session. At this particular juncture, I would want us to quickly move into the official opening. I would like that we all be upstanding for the national anthems. National anthem. Ifri. Very have a seat. When there was a bit of a hitch, I saw the governor hinting that I should start it off and sing it in English. Your Excellency, the Governor, Honorable Gideon Mngaro, Your Excellency, Mohammed Mbarak, the Deputy Governor of Lamu, and also the CEC in charge of health. Your Excellency, Honorable Peter Morogo, the CEC for Health. Professor Malin Tamaman, the Chairperson of the Kilifi County Health Stakeholders Forum, and all the partners present. And all the partners have actually made the place very beautiful by dotting around with their posters and flyers. The academy represented here today by Professor Halimu Shauri and also Professor Ajim from Abraham International University. Research institution who have joined us here, led by our very own Kemri Welcome Trust, represented by a few years. Students, ladies and gentlemen, partners, good morning. I wanted to acknowledge those protocols, and everyone else will stand on those. Allow me to quickly invite some people to make very few remarks as we look at office particular. I need to invite Ben Kito, please take your seat here. Dr. Asaleli, please do take your seat. Dr. Sfioyaga, please do take your seat. And Professor Malin Taman, please do take your seat. You will have a minute each. Kile, you will do reflections on the research symposium. Hasaleli, you will reflect on the county government of Kilifi and where we are going. Malin Tamaman, Professor, you will reflect on the role of the Stakeholders Forum, which you chair. And our good friend, Dr. Sophie, you reflect on the ongoing relationship that we have with Kemri and here. Please, let me start with Ben.
Thank you very much. Thank you very much, Your Excellency, our Governor, Kilifi, Honorable County Executive Members, distinguished guests, researchers, clinicians and policymakers who are here. Good morning. On behalf of the Research Committee, I wish to raise a small speech. It is a great honor to welcome you to this third Kilifi County Scientific Symposium. Today we are gathered here not only to share scientific work, but to celebrate a remarkable journey. A journey of growth, a journey of learning, and unwavering commitment to improve the health and well-being of our people. Our scientific journey as a county began in 2019 June. During which we had a symposium held at Mnarani, a club, with a theme convening and tackling big health issues by strengthening health systems towards UHC. That inaugural convening laid a foundation for cultural evidence generation, evidence use, and collaboration within the Department of Health. Ladies and gentlemen, this year's theme could not only be more timely. Donor support for many years cushioned essential health programs continues to decline today. At the same time, the health needs of our people are expanding and becoming more complex. This moment calls for innovation, resilience, efficiency, and smarter use of evidence. Research to Kilifi County is not a luxury. It is a backbone of a strong and responsive health system. Whether we are assessing maternal and child health outcomes, investigating emergency diseases, or evaluating performance of primary health care, or strengthening the shift alignment, or designing sustainability approaches towards NCDs. Our work today must translate into informed decisions and better health care for our people in Kilifi County. Ladies and gentlemen, over the next 2 days, we're going to be here. We will engage with evidence from within and beyond our borders. We will reflect on innovations that are strengthening services delivery at the facility level and community level. Also, we're going to reflect on strategies for improving immunization, nutrition, and other health services. At the same time, we're going to reflect on responses to the triple threats that our country is actually facing today. We are going to look at issues of integration and approaches to the rising burden of NCDs and lessons learned to operationalize primary health care in our community. I represent students, researchers, citizen scientists, the academics, actually to doing it fully. Let's explain challenges and offer new ideas. Secondly, fast many parts of Jiku, Caris, Don't seek care, community promoter who is there things at community level going home, and the residents and the elderly citizens who are living with chronic diseases. Researchers to match them. Ladies and gentlemen, this morning, let us pause here from our commitment. Every shilling invested in healthcare is getting evidence, and every policy shaped is shaped by data. And every event is grounded in the real needs for our committee. This year, we are only going to have Symposium and leading research papers, but also we are going to host a gala dinner. This gala dinner, I really want to welcome all of you to be there. In the gala dinner, we are going to celebrate good performance of continuous quality improvement in service delivery, where service delivery is going to, best performers are going to be recognized, they're going to be appreciated, and they're going to be rewarded, so that we can be able to motivate the service providers to continue improve the quality. Thank you very much for being part of this journey. I wish you a productive and inspiring transformative sitting, and may God bless you.
Thank you very much, Dr. Hassan. Very few comments.
Excellency Governor for our great county, Kilifi. Excellency Deputy Governor for Lamu, our CCM, Health Services, CCM, Education, distinguished colleagues, stakeholders, partners, and friends of Kilifi County, good morning. I have a speech, but I'll try to make it as short as possible. It is a pleasure to join you as we open the third Kilifi County Scientific Symposium, a gathering that continues to grow into one of our most important platforms for advancing quality and sustainability of health services in our county. I'm particularly inspired by this year's theme, sustaining universal health coverage amidst reduced donor funding. The reality we face is clear. Donor support is that once cushioned our health programs is declining. Yet our responsibility to deliver equitable, accessible, and quality of health care for all remains unchanged. This is why we must focus our shift to strengthen our systems from within. We must innovate in service delivery, diversify our funding sources, and prioritize efficiency in the use of available resources. Research is a key enabler of this transformation. Evidence allows us to identify gaps, test interventions, scale up what works, and discontinue what does not. Across the therapeutic symposium, we see the habit of mandate the health department. And these priorities to the everyday realities of our communities, we must endeavor to make sure we deliver our mandate. To extend to the researchers, meetups, institutions who supported them, and the committee that ensured the rigor of this symposium. Your work enriches our decision making and strengthens our resolve to deliver better health outcomes. Let us use these 2 days not only to learn, but also forge partnerships that endure beyond this event. Sustainable universal health coverage in Kilifi County is possible, but only if we commit to innovation, collaboration, and accountability. Thank you all, and I look forward to the knowledge that will emerge from our engagements. Thank you.
Thank you.
Your Excellence, Honorable County Executive Members, distinguished guests, researchers, practitioners, partners, students, colleagues, ladies and gentlemen, very good morning. I'm happy to talk to you this morning as the chair of the Kilifi County, the co-chair, the government is a chair, the Kilifi County Stakeholders Forum, and I've seen the evolution over years. I didn't do a 47 county studies, maybe one of the students could do that, or group, to assess the quality or the impact of the county stakeholders forums. I have seen a few of them, and I can say that as far as I know, Kilifi County has the strongest and the best Kilifi County Stakeholders Forum, bringing together all the partners, led by Waziri, of course, but bringing everyone together, not just to, as we did maybe a bit in the beginning, everyone telling what good they are doing, but really putting it together through technical working groups and to come to a conclusion. Because, of course, I'm a researcher since many, many years. I value research, I value data, but I've also seen that data are there. How do we really translate data to impact? We come with data, we come with publications, we come with innovations, this is great. But what is the proportion of it that is really at the demand of the county, that is really needed by the county, that is a priority by the leadership of the county? And how can we work together really to increase, to leverage impact? Because this is still a big thing. We have publications, we do a lot, but how do we measure really the impact in this county and counties in general? So I think the Kilifi County Health Stakeholders Forum is a strong mechanism. As I said earlier, we have many, many partners. Some of them have left and we even don't realize, but we remain with a group of about 30 that are very actively under the leadership of the governor and the Waziri to kind of guide us on what are the priorities for the county. And this is really our wish. This is why we are here, and I thank you very much.
Good morning, everyone. Your Excellency, the Governor of Kilifi County, Deputy Governor Lamu, Waziri Mwarogo, ladies and gentlemen, all protocols observed, good morning. On behalf of KEMRI, I'd like to first start by expressing deep gratitude to the county government of Kilifi and the people of Kilifi in general for allowing us to be present in this great county and to contribute and have research that works within the community and works with the community for the last, I think we've been in Kilifi for 38 years. So it's been a really long journey. We've seen the transition, we've seen the improved. What people are talking about, we've seen it. We've been there from the start, and we really have to applaud you for the progress made. As KEMRI, our commitment is to support the county government and the practitioners and the policymakers by generating evidence, and also by supporting capacity building through a very strong trained program for student voters. So if a project you need to know if opportunities that we will support and it's up to here. Thank you very much for recognizing us, and we do look forward to having a great engagements and coming up with action plans to improve the health of Kilifi. And then is of the next.
Thank you very much, colleagues and partners in this. Allow me this particular juncture, please to have your seat. Allow me this particular juncture to welcome Honorable Peter Morogo, DC Charge to the Governor. My name is House Kamau, I've been your moderator. I'm here at Partnerships.
Thank you very much. Thank you very much, everyone, for making it speak. Your Excellency, Governor Gideon Maita Mung'aro, first of all, it's my singular honor to thank you for agreeing to this occasion. I know your schedule today is very, very tight. First, you know, it's really a privilege for us to have the governor here, because I know his schedule is such that, you know, we were almost not very sure he was going to come. But this means the commitment he has to the health in Kilifi. So we really would like to thank you. But before I welcome you, I would like to ask, are there participants from other counties? Can you raise your hand? Are there stand so that we recognize you? Participants from other counties? Thank you. Thank you very much. So before I welcome, thank you very much for coming to participate. Before I welcome the governor, I would like to acknowledge the presence of my colleague, CC. We were talking about, you know, sectoral collaboration. So I have here the CC for Education, who is here. So it's very much part of the meeting. So just to greet the people here, his voice, please.
Your Excellency, fellow CC, Department of Health, all protocols. Good morning. My name is Fel Kindena. I'm the CC of Education, Vocational Training and ICT, and Innovation. So when you talk about innovation, I'm the father of innovation in Kilifi. I'm very much humbled to be today. I think we have developed some data management systems for the Department of Health. We are also giving fortified porridge to those students in PP1 and PP2. That is part of the preventive measures. We have developed the emergency number for the Department of Health, again, 1535. You can use it. That is in my docket. We are also in the process of developing a disaster risk management unit, which will be used for data sharing. So thank you very much. I'll not talk more. We are working collaboratively with the Department of Health. Thank you very much, Waziri. Mungu akubariki.
Thank you. Very much. I would also like to take this opportunity to welcome the Deputy Governor for Lamu, who is also the CC for Health, Dr. Mubarak, who I know he has also a very, very tight schedule. He was scheduled to have a session tomorrow, but because of other duties, he'll not be able to. So, but at least he made the effort of coming to join us. Welcome, Dr. Mubarak.
Excellency Governor Kilifi County, Gideon Mung'aro, Waziri Health, Mzee Peter Morogo, all other partners present here, and friends of Kilifi, good morning. Consider that a warm greeting from His Excellency Governor Issa Timami as well. I wish to take this opportunity to thank and appreciate my colleague Waziri Morogo for inviting me to this forum. I was passing on my way to Lamu, and I said I'll come and show support to this landmark event of yours. I congratulate you immensely for this great initiative. And Kilifi County is an elder brother to Lamu on matters healthcare. I remember back in the day when we did not have an ICU and Coast General was being Coast General. We always turned to Kilifi for support, and they've never turned us down. At least now we have our own, and we still collaborate on a lot of issues. I would like to distinctly appreciate the panelists who were here earlier, and the aspects that they picked Dr. Noel speaking about the multifaceted nature of healthcare. And you know, as a person right at the top there, for our people, all they know about healthcare is dawa ziko hakuna. Kama dawa hakuna, nyinyi bure kabisa. They don't want to know sijui umeleta robotic surgery, sijui umeleta nini. Dawa hakuna, hii ni hakuna kitu hapa. So the multifaceted nature and the complex nature of healthcare, there is more than dawa zipo hakuna. And I want to agree with Professor Benjamin when he clearly stated the gap that is there between data and decisions. And I want to tell you that what there is goodwill. And I want to a special mention and appreciation to Excellent Governor Mungaro and the Governor. I can confidently say these two governors have kept health and I believe we will do well. One of the solutions I believe is the tools. His Excellency the President among the follows that he pushed and enacted the Social Health and Facility Finance Act, which I believe Lamu and Kilifi are implementing fully. These are some of the strategies that will empower our facilities to take those decisions based on data. If money to go down to facilities, then the administrators, who I want to believe most are medics or healthcare workers, who feel maybe the biggest pinch from data, they'll be able to take those key decisions to be able to make a difference. However, we still have a long way to go on these two laws. One, on FIF, there is a matter of it being complementary or a substitute. I think this is where we've not converged with finance people. They interpret it as being a substitute. We, in the health space, we interpret it as complementary. So then we get stuck. If it becomes a substitute, then you are basically commercializing healthcare, and it becomes a burden to the patients. And then you have the other animal, that is SHA. So nitawauliza, SHA inafanya haifanyi? Haifanyi. Kilifi anasema haifanyi. So SHA, there are two aspects of SHA. There is the side of the patients and there is the side of the health sector itself. It's supposed to be a two-edged sword in a good way. However, it may be working for patients on matters inpatients and surgeries. It is not working for patients on matters outpatient. It still needs streamlining. It needs more funding. But on our side, the health administrators and the leaders, we have a big problem. We are not getting paid by SHA. So how do we realize FIF if there is no money? How do you do facility improvement if there is no money? So sisi twadai SHA 71 million. I know Kilifi labda mnadai over 300 million. So all that money, if it goes to the facilities on time, then we are good to go. And I want to finally agree with Mwalimu from Pan University that we are supposed to go the pre-pro way, prevention and preventive and promotive. However, we have a burden to deal with. We've neglected health for quite a while. So we have no other way except to strengthen our facilities to be able to deal with all the cancers that we have, all the high blood pressures that we already have, most of them complicated, etc., etc. I wish to stop there. Thank you very much, and I wish you well in this initiative. Thank you.
Thank you very much. At this stage, I would like to ask the audience to stand as I welcome His Excellency to come to the podium to open our conference formally. Thank you.
Asante. Get seated, tafadhali. Thank you very much.
distinguished researchers, healthcare professionals, policy leaders, development partners, I recognize all the protocols which were established earlier by the rest. And the great people of Kilifi, good morning. It is my profound honor to welcome you to the third Kilifi Scientific Symposium. Today we gather as a community of innovators, practitioners, scholars, and leaders, each of us committed to advancing the health and well-being of our people. I am delighted to join you as we reflect, learn, innovate, and chart the future of healthcare in a rapidly changing world. This year's theme could not be more timely. For decades, donor funding has strengthened health systems across Kenya. But today, as those resources decline, we are saying of delivering health clarity and mission. However, our shared values to the resilience sustain with strength of strict population, improve change, enhance emerging social investment, and ensure equal of across facilities and communities. Our goal, I insist that if we continue to run for meaningful homegrown innovations, from digital disease surveillance and certain community health systems to emergency care models and grassroots partnerships. These are not theoretical ideas, they are revolutions. These symposiums elevate the successes and challenges as go further to scale our works, improve and invest in solutions that are Kenyan, evidence-led, and future-proof. It's all health, but it's only about illness. It's about well-being across the entire life. That's what Professor was saying earlier. The idea was right when we started the session, and some of us were waiting for radio to do it. The Symposium, immunization, maternal and newborn health, policy and care, family planning, nutrition, geriatric, doctor, and then proposal and proposal. Care must UAE demands a holistic approach. We must also confront the persistent triple threats, especially gender-based violence and teenage pregnancy. Address the challenges requires integrated interventions, community trust, and all prevention strategies. I believe the conversations here will significantly strengthen our collective response. We live in a time of dual disease and recurring infectious diseases on one hand and rising and communicable diseases on the other. Our response to preventive, data-driven, integrated across levels of care, anchored in research and real-world evidence. Symposium provides the space at the sustainable models in leadership. A strong primary health care system is the backbone of universal health coverage. Kilifi has made strides in operationalizing primary health care networks, but we must go far and further. Our vision is a health system where every resident, no matter how remote their location, can access timely, affordable, and quality care without financial hurdle. Your deliberations over these 2 days will guide how we invest, how we implement, and how we accelerate this effort. This gathering is not ceremonial. It is strategic. Research data and evidence generated here translated policy direction. Budget priorities, and at past. With the main story. Commend the Department and Sanitary hosting for this post and position in Kilifi as whole of require evidence and learning exchange. As we begin these 2 days sessions and discussions, I challenge one of us to build build models that outlive age and partnerships of our communities and above all, be patient to the system at the center of everything. The Symposium is just evident where it must be towards for collaboration experiences to our organizers, the scientific committee, your education and your knowledge, which is a same further interest with build or not government and officially let the thief count and tip open. Thank you very much for coming. I want to do that as Morocco's door. I encourage you. We have started the festivities after 2 leaves and what you've left. Also, we are doing tourism. We also want to help. We also marketing tourism. So, as our part of our investment and the sort of revenue for this country, please don't go live nice. After that one, you go talk back with Shula. Merry Christmas, Happy New Year.
Thank you very much, Your Excellency. Maybe now be handing the chances of your main conference. Here, let's see. Only one piece. Mungu. Thank you for challenging me, Excellent. Allow me to now invite His Excellency to make very brief to all the exhibition areas. This is Professor Huri, and the rest invite us. So now we are now taking tea. We'll break for tea and we'll be back here by exactly 12. We are going to break for tea and be back at 12 with the first plenary on maternal child. Thank you.
Gomez, who is the chair of that particular session, to take it from here. For you who are outside, please, let us get back to the
Please, let us maintain silence.
Thank you so much, Charles, for introducing me. Welcome all. Those who are outside, please come back in. We're about to start with our first plenary session for this symposium. And our first speaker will be Professor Marlene Tammerman. She's been introduced so many times, so I won't go into the details of it, but she is the chair, Kilifi County Research Committee, the chair for Kilifi County Health Stakeholders Forum, and the Director Center of Excellence in Women and Child Health at the Aga Khan University. I am going to ask you to please put your phones on silent so that we can hear everything that's said here without interruption. Prof, please, karibu.
Thank you. A very good morning, afternoon, sorry, to all of you. I think after this session you will have seen me enough for the rest of the symposium, I guess. But I was asked to, shall I wait till everyone is kind of finished the talks? Let's try again. A very good afternoon and welcome to this session. I was asked shall I continue or do I wait a bit? What do you advise? I continue? Okay. So I was asked to talk about maternal and adolescent health, women's health actually. And my CV, as you can see here, I'm an MBS, very proud to be an MBS here in Kenya, and a medical doctor, OBGYN, and I spent most of my life in academia, in Ghent University, where I come from, University of Nairobi, Aga Khan University. I'm also the founding director of ICRH, but I made a switch in my career when after being invited by my friends, I accepted to run for politics. That was never the plan. But I did, and I became an elected senator in my own country. So I joined the Senate. And why do I say this? Because it really was for me a kind of complete new experience, but also learning that if you want to move something and you come from one constituency, it's very important to work with different constituencies, be in public health, media, academia, communication, and also politics. And I want to take you back. Could we close the door a bit? The noise is really... I want to take you back. Learning from the past can help us to shape the future. This is the UN Secretary General Ban Ki-moon, and something that you might all remember, being the Millennium Development Goals. We had 8 of them. The aim of the Millennium Development Goals was to eradicate poverty. And you can see, do you remember these goals? Sounds familiar to many of you? So, after 10 years, Secretary General Ban Ki-moon decided to assess the progress made with these 8 very aspirational goals. And the one lacking behind most was which one? Millennium Development Goal 5. Saving mothers' lives was more difficult than anything else in the goals. So why was that? Because it has a lot to do with women's rights. The right of a woman to decide when she wants to get pregnant, with whom, and how many children she wants. So the UN decided to focus, to bring everyone around the table, not only the UN, not only the private, public, the governments, but everyone, communities, around one topic, every woman, every child, EWEC. Right now it's called, what is it called in Kenya and globally now? EWENE, right? You know EWENE, every woman, every child, every newborn. So what was done? Everyone around the table, and it was successful, because one of the great successes of human history is indeed the effect on improving maternal and children's health. Did we improve? The goal was reduction of maternal mortality by 70%. We didn't get there, but we managed to reduce maternal mortality. And when I talk about maternal, very close to it goes stillbirth, goes neonatal, perinatal mortality, goes together with maternal. So we reached 40% reduction, thanks to a kind of a collaborating effort of everyone. More money was put because it was on a high political level. So remember what I'm saying. If you want to raise funds, if you want to raise attention, if you want to do anything, you have to make sure that your topic is on a high political level. And that's what happened at the end of the Millennium Development Goals. More stakeholders, more money. You can read the figures there, more global initiatives, more innovations, more research and everything. So, what were the lessons we learned at that time? What works? Political leadership and commitment. How many countries in Africa managed to reach the Millennium Development Goals and the number 5? Only 2. Those where the president himself at the highest level took the leadership. And not only the Ministry of Health, but everyone. Finance, education, all the ministries, parliaments, everyone was called around the table and was involved in moving the agenda forward. As we said already this morning, multi-stakeholder partnership, accountability, and what could work better, and the same, this is 2015, but it applies to today. We said this morning, what can work better? Country plans, priorities, coordination of existing initiatives, country leadership, reduced fragmentation. And we, stakeholders, donors, very often we work in fragmented situations. So, and now it's blocked. So you will recognize some leaders in 2015. Our former president was there, and then Ban Ki-moon and others, who said now we need a global strategy, a new one, that brings us to 2030. A global strategy for women, children, adolescents. Not only focusing on surviving, but surviving, thriving, and transforming. Transforming what? Health systems. So we published a lot, and we said we know what needs to be done. Let's do it. We learned from the previous MDGs, so we can end preventable maternal and newborn mortality and stillbirths in 2015. Did we reach it? Are we there? 2030? Not yet. Far away. So what needs to be done? Strengthen care around time of birth. Health systems, reach every woman and every newborn, harness the power of parents, families, and communities, and improve data. So every country, and now I want you to pay attention to this, because if we listen to leadership everywhere, what is the aim in the maternal mortality rate by 2030? Do we know that? Somebody? Nobody knows? So, then let me inform you that the global, but pay attention, the global maternal mortality target is less than 70 per 100,000. Now, what is the Kenya government saying? Our goal is 70 per 100,000. No, that is impossible. Countries who come from a very high rate, so not one country should have more than 140. But we don't have to reach 70. 70 is global. There are countries in the West who have a maternal mortality rate of 10, 20. So the 70 is not the target for Kenya. Every country had a specific target. And I think the one, if I remember well, for Kenya was 149, based on the numbers we had in 2015. Are you with me? So if you give a presentation, never say, we don't reach in Kenya the 70 per 100,000. We shouldn't. We won't. But that was not the target that we agreed on. Same story for stillbirths, 2.6 million. We are still there. Half of the stillbirths occur in labor. And that is an indicator of what? You know, all of you are in the field of maternal health. Those who know that you can have a macerated stillbirth, that fetus died during pregnancy, and then you have a fresh stillbirth. That fetus, that child is dying during labor. So half of them during labor, what does that show us? Quality of care during labor, right? So if you have many fresh stillbirths, means your quality of care during delivery is in a problem. I was the director after my political years in Parliament. I moved to WHO, where I became the director of the Department for Women's Health and Research in Geneva. And there we worked a lot on quality of care. Now, two main interventions. If you want here in Kilifi to improve quality of care, you want to reduce maternal death, you want to improve maternal health, there is a lot you can do, but two interventions have really shown to be possible, to be cost effective. That is number one, quality of care during labor. Of course, antenatal care is important and postpartum, but most women die when? During childbirth. So quality of care in labor is very important. And number two, what is the most cost-effective intervention? Family planning. And innovation is now in those times. So if your quality of care is like this, right, or like this, or like this, then you have a problem. You will have not the best optimal quality of care. And I'm happy that even the governor now, when he was going around, he told us about somebody wants to comment on this one? That's what we call in obstetrics gentle pushing, right? So now, I know a lot of people are commenting on the picture, but I would like to move on. So remember, quality of care in labor, right? Number two, family planning. If in 1 out of 3 deaths could be avoided, if women have the power to decide on their reproductive lives, if they have the power to decide, I want 2 children or 3, I don't want them one after the other, I want this care. So a lot of it has to do with women's reproductive rights. We did a lot of research, papers, modeling with health economists, and it is really possible. So at the end of the Millennium Development Goals, we were saying no woman should die while giving life, no child dying of stunting, no newborn, but we see that we are still far away from the goals. Now that brings us to the new, where we are now, the Sustainable Development Goals. Many more goals, 17, many more targets, a much more comprehensive agenda. But are we doing well? Well, there is the unfinished agenda of the Millennium Development Goals, and then there are the new. In the Millennium Development Goals, we never talked about adolescence. We never talked about mental health. We never talked about NCDs. So the agenda is much larger. And then we had, of course, the COVID epidemic. We have now environment. So the agenda is much more comprehensive. But for maternal mortality, we know the causes of that, right? Everywhere in the world, we have the bleedings, we have the hypertension, we have septicemia. So we know the causes of maternal mortality. Why are women in Africa dying of that and in other countries less? Because, and you know, if you want to express it differently, 800 women die every day in pregnancy and childbirth. Imagine that 2 Boeings, 2 airplanes are crashing every day. It would be a big scandal. Maternal mortality, we even don't talk about it. So let me quickly move. Now, the last thing about maternal mortality is that it's going up again. So at the end of 2015, we had reached some good achievements, but now it is so bad, going up again, that last year in the World Health Assembly, countries were asking WHO to renew the call for child survival. Now, looking at Kenya, what is the county, and you can all look in detail, where is your county positioned in the facility? I'm not talking about overall maternal mortality, but in the facility maternal mortality. Here you have the recent data per county. And Kilifi, I think, is number 13. But look at the numbers we are dealing with. The MMR, according to KDHS, is what? 355. According to the World Bank Group, a few years ago, 149. What can we say about these figures? They don't add up. So the county, if you look at the counties, most of the rates are around 160 per 100,000. Now, think with me, if 90% of your women are delivering in facilities, and the facility maternal mortality rate is around 160, can your country population maternal mortality rate be 550? No way. Even if all the women who deliver at home would die, even then you could not come to these statistics. So there is a big, big, big problem with data. And the president is very annoyed because every time he goes to UN and they are talking about Kenya is put up there as a country with a high maternal mortality, not going down. I don't believe these figures because the ones that we have for sure are the maternal facility data, and they are much better. So it's high time that something is done on this. It's not moving anymore. Yeah. So one of the great instruments that we are having, and I think Kilifi and also Mombasa, sure, and other counties, they are doing what? MPDSR. Now, MPDSR means that everyone comes together who has been involved in a maternal death or a perinatal death. Counties like, I think, Kilifi, it's on a Wednesday evening. Mombasa, Tuesday morning, 100, 200 healthcare providers are joining. A very good presentation is made of the case, what happened, then analysis, conclusion, was this avoidable, what can we do better? So we have all this data and we should publish them. But even if you are there in the MPDSRs, today you hear about a mom who died because there was no blood available, and you make your analysis, great, action plan A, B, C, D. 3 months later, you are in another MPDSR and you repeat. It's like a broken record. So what I'm trying to say is MPDSR is a great instrument. Action plans are often failing. We just repeat ourselves. And one of the, and I need another 2 minutes, one of the quotes that I want you to remember, to learn by heart, Professor Mahmoud Fatala, an Egyptian gynecologist, who was saying, women are not dying because of the diseases that we cannot treat. They are dying because of societies have yet to make the decision that their lives are worth saving. So preventable mortality is number one, childbirth. How many women do we lose every year in Kenya? 5,000 to 6,000. Most of them preventable. But there are other things. Cervix cancer, we talked about it already. HPV vaccine is great. What is the coverage of HPV vaccine in Kenya? 20%. In a country like Rwanda, 90%. Sorry to come back to Rwanda, but so it is possible to do it, but we need to work together, because we work together with the schools, with the health sector, with leadership. This is a thesis done by a Kenyan PhD student. I'm not going to read it, just saying that we have in Kenya great documents. We have strategies, country plans, we have policies, we come together a lot. Everywhere we have documents, but our screening coverage is less than 20%. Even we have, in cervix cancer, we have everything. We have HPV, vaccination, we have the screenings, we have the early treatment. We can prevent women from getting cancer and dying. Still, we are not performing very well. So the system is unprepared for scale up. We work a lot with the Ministry of Health, a lot of meetings, but very little impact. And the other lady killer, so we had pregnancy, we had cervix cancer, and the other lady killer, and all of them are about 5,000 to 6,000 per year in Kenya, remember. So is breast. Breast cancer is very, very common. You can prevent it if you do screening with mammography, but we don't have the systems in place. So we are now preparing with new technologies, what can we do to have better diagnosis, maybe ultrasound, AI-enabled, etc., etc. So then a few words on the, it was already mentioned this morning, I talked about the women, maternal, cervix, breast. Then another topic of my presentation was a triple threat. And what is a triple threat? I mentioned already new HIV infections, most common in young girls and pregnant women. Pregnancy and postpartum is really a big, big risk area for new infections. Gender-based violence, adolescent pregnancies. And Kilifi is one of the counties really working hard in this area. You have already strategies for HIV, adolescent health, but now we have to implement them. And the triple threat, UN agencies are joining, they are calling upon everyone to join, and Kenya has launched a very ambitious plan in 24 to end it in 27, but nothing has happened since 24. I'm going to skip these ones. These are my great teams. They are all here. I just want to say they are working very hard, because my number one was quality of care in childbirth. Number two was family planning. Number three was integrating innovation and technology. So here you see new technology and ultrasound and new technology and AI. We don't have time to go in the details. Evidence-based advocacy is needed for the policy reforms. We made partnerships, as you can see here, with the governor and Waziri. We were involved since more than 10 years in community health, in developing the strategic plans for the government. And we were even, and now just I want to end, I want to just show you, and it's outside there, a new program on sexual and reproductive health and rights. Because in the current political and financing ecosystem, there is almost no money anymore for SRHR. It's really gone down. So we are happy to say that the Canadian government is supporting Kilifi with the program called Strides. It's Kilifi County in the lead, supported by the Aga Khan Foundation, Aga Khan University Health Services, and partners such as ICRH and Moving the Goalpost. One of the things there is also something you can see outside, a Pioneer mobile lab, which is really top-notch technology, because in Kenya there are 6 labs who can provide this technology for like new infections, Mpox, whatever, and there is number 7 that is a mobile one. So 6 are in the facilities. This one can go around to any part of the country too, and we did when we launched in Ganze the program last month. We offered this screening for cervix cancer with Gene Expert, and there were immediately, the results are known immediately. Out of 36 tests done, 11 were positive for cancer, for oncogenic HPV. So to end, I think we were involved in the very first health research forum in 2017, I think, or 18. First time that Ministry of Health and the research communities came together and we learned a lot. Second, the Kilifi Scientific County Symposium was in 2023, and today we are now in the third one. So in conclusion, I would say a big thank you. Thanks to Kilifi County leadership, and congrats for moving this agenda forward together with partners and for organizing this symposium. Congrats also to Kilifi County, and I know Waziri is there, but our director is here to really working hard with everyone to the progress, and more has to be done, but the progress has been made in, we always say Kilifi has the highest number of teenage pregnancies. I'm not sure about that. I think we have managed to take it down, and we know how to do it, because it was really great result, and I hope that Kilifi, because Kenya is making less noise about child marriage, less noise about all these young girls who get pregnant, teenage moms, so many, we hardly talk about it a bit, and we make more noise about that than availing contraceptives for the young girls. We could avoid so many teenage pregnancies if the young girls also had access to contraception. And I think that's really something, of course that's a policy and politics, but that we really should. Why don't we care about all these child marriages? What do we say about the young girls? And even worse now, because here in the region, and not only Kilifi, a lot of the young girls who get pregnant below 18, can they access SHA? Many of them don't have an ID. So we see that maternal problems, HIV and neonates, is going up. You know, because we have less pregnant women, and surely the very, very vulnerable, the young girls, who have more problems accessing healthcare than ever before. So we should also target these ones. We want to appreciate recognizing these challenges. And as I said already this morning once or twice, calling upon all the partners who are here and those who are not here to really work together under the leadership of Kilifi County government, and in particular Department of Health, but of course with all the other departments, because together we are always saying, you know, if you want to go far, if you want to go fast, but I think together we can go far and fast. Thank you.
Thank you so much, Prof, for sharing so much of your wisdom with us. I'm sure there's a lot more, it's just that we don't have time for it. Okay, so in the interest of time, for anyone who has questions for Prof, we'll keep those until the end of the the question session at the end of the midway in this session. Sorry, there's so much going on. Anyway, so we'll welcome a speaker who was supposed to talk tomorrow, but because she will not be in tomorrow, she will come and give her talk now. This is a pointer to those who are judging. This fits in the plenary session 4 for tomorrow. So please, as you judge this one in that section. Her name is Noni Mumba, and she's the head of engagement at Kemri Wellcome Trust Research Program. Karibu Noni.
Asante sana Nancy. Good afternoon, everyone. Hi. Please wave at me. Thank you. I just want to be sure you're all awake. So as Nancy has rightly put it, first of all, I'm not Gladys Sanga. As she said, my name is Noni. I'm making the presentation on behalf of Gladys. She was supposed to do the presentation tomorrow. She got an impromptu but urgent meeting in Nairobi that she needs to attend to. So I'll do the presentation together with her. Coming off the talk by Prof. Malin, talking about maternal and adolescent health. This is a bit out of that topic, but it's still related because it's about populations being able to access health services during extreme weather. And one of those very important populations is women, especially women who are pregnant, young children below the ages of 5, and how they are able to access. So it's related to just the talk that has just ended. This is work that is embedded within a project that is in its second year now, called the New Risk Project, a novel extreme weather risk insurance system for Kenya. That's the full name. In short, it's called New Risk, a project that is funded by NIHR, National Institute for Health and Care Research in the UK, and we are implementing it as Cambridge Wellcome in collaboration with the University of Oxford. So I'm presenting some findings from work that we have been undertaking in the course of this year, just finding out community members' perceptions about extreme weather related to climate change, and some of the coping strategies that they have to ensure that they can still access health services when extreme weather events happen. So we've been undertaking this work in the 7 sub-counties of Kilifi, all the 7 sub-counties, talking to facility management committee members, talking to community health promoters, and talking to community members about extreme weather events and how they manage them. So the outline of my presentation, I'll just give you a brief introduction, what our objectives are for the work that we've been doing, the methods that we've used in collecting data, some of the findings that we have gotten, our learnings, and then, yeah. So we know that climate change, everybody now is talking about climate change. It is adversely affecting human health. But more so we saw in the recent past, I think people might be aware of the cyclone. I don't know if it was a cyclone, but the thing that happened in Malawi, where a whole region was completely flooded and health systems were completely devastated. We've had the same in Kenya here, around 2023, 2024, where we had the El Nino. There was a lot of flooding. So we do know that already climate change is affecting health and affecting health systems and health services. We know that community members are also affected. When health facilities are not able to offer services, community and health services are also affected. Some of the best approaches that have been put out there in terms of being able to meet the effects is partnering with community members. So that's what we are trying to do, to see what do community members know, what are they currently doing, and how can we best partner with them. So the extent to which community priorities are able to inform the development of solutions is not yet known, especially in the area of climate and extreme weather. So our objective for this work was to examine community perspectives towards extreme weather, health system mitigation strategies, and how to communicate climate risk data and eventually co-create health system risk mitigation together with community members and other stakeholders within the health sector. So we have 3 objectives. The work that I'm going to be, the findings that I'm going to be sharing relate mostly to Objective 1 and Objective 2, the first 2 bullets, just exploring community understanding of climate change and extreme weather and their perceptions, and also just trying to understand what their priorities are related to climate change and health. So we undertook some piece of work. We conducted some community consultations. We developed a tool, and then we used the tool to do community consultations. We did 14 consultations across, as I've said, the 7 sub-counties of Kilifi County, and I've already said that we talked to CHPs, community members, and facility management committee members and facility boards for larger hospitals. So on to some of our findings. According to the groups that we spoke to, the community members, FMCs, CHPs, what they think is causing or can be causing climate change is industries, for one, deforestation, and for some they felt it's actually a punishment from God. So from that quote down there, I had people saying that climate change is a punishment from God, that we've committed so many sins that God is punishing us. And this was really related to some of the atrocities that has happened, for example, in Shakahola, the things where that have happened in that region. People felt we are doing so much ill to one another that God is taking away our rain and changing the climate. And as you can see on that photo, the deforestation was related to overgrazing. You can see camels there. There's lots of, nowadays, lots and lots of herds of cows in Kilifi County. And then, of course, you can see the border there with charcoal. So charcoal burning being another source of climate change. So in terms of extreme weather effects to health facilities, we asked the community members what do they think some of the effects of extreme weather events to health facilities. So they talked about reduced access to health services. So when there's an extreme weather event like flooding, people are not able to access health services. They're not able to attend to health facility. They cannot reach the place because of flooding. Increased patient workload and straining of the limited resources. So they talked about limited health workforce and the fact that when an extreme weather event occurs, then the facility is not able to cope. So in terms of coping strategies, we asked them what do they currently do. And they talked about adopting alternative service delivery methods. For example, one facility management committee member said there were problems at our facility caused by the floods to the extent that it had to be closed and the people had to be treated outside. So a mobile clinic was brought in because the place was completely flooded. Some other coping strategies is offering first aid. So community health promoters said that they are able to step in and provide some basic services in the population when an extreme weather event has occurred and people are not able to reach the facility. For community members, they said what they do when extreme weather events happen is that some of them have been hosting healthcare workers so that they don't have to cross a river and go back to their home. They stay within the village so that they can be able to, and they are hosted by the community members there. In terms of learnings, one of the things that we learned, one of the first questions we were asking them was, what are the priorities of community members in your region? And we got the sense that climate change was not the top of their minds. Rather, they would share things like, we don't have access to water, our road systems are very poor, we don't have medicines. Those are the kind of things, the very immediate needs for them are what are a priority for them, as opposed to climate change. Another learning was that we may feel like extreme weather events happen and maybe people are stranded, but in actual fact, community members team up with the healthcare workers and they are able actually to devise coping strategies so that they can move forward with giving health services to community members. And then they felt that there isn't really guidance from the top in terms of being able to guide them on what can they do when extreme weather events happen. And that they are willing to participate in development and strengthening of adaptive capacity. Thank you for listening to me. Santeni sana.
Thank you, Noni. In the interest of time, our next speaker is going to be Benjamin Kihika, who is a monitoring and evaluation officer from Helen Keller International. Karibu sana, Ben.
Thank you so much, Nancy. Good afternoon. Yeah, good afternoon. Thank you so much for this opportunity. I thank the county team and the management and everyone who is here. Allow me to... Okay. So thank you so much for this opportunity. First, thank the county for arranging this and also for giving me this opportunity to present this to you guys. Thank you so much. So my topic is on barriers and promoters, specifically looking at breastfeeding among the caregivers. Our target population in this study, we were looking at the children of age 0 to 23 months, and we did this in all the 7 sub-counties across Kilifi, where we had interviews at the household level, as we will see. And it falls under that theme. So this is the outline of the presentation. Give a small background. I'll also give an objective, which basically I've mentioned, the methodology that we used when we're doing this research, and then we talk about the results and some of the conclusions. So as we all know, the stunting at the national level, Kenya to be specific, 18% of children remain stunted, and this is according to the KDHS. And I know we also know that Kilifi County is the #1 in terms of stunting, and we're talking about children that are stunted. These are the under 5s. And we have interventions that are related to combating this, and we know all the reasons that could cause stunting, but some of the interventions, specifically those are related to nutrition, that we have ongoing from breastfeeding and promotion facility level, the community level, and the continuation of the same up to the age of 2 years for children, that can greatly reduce the mortality rates among the children. And we acknowledge that this data is available at the county level, majorly through the KDHS, but the knowledge and practices, the attitudes among the caregivers around breastfeeding is yet or is not available, especially at the sub-county level. So these were some of the bases in terms of why we did this study. So one of the objectives, I paint the broader objective, which was to assess the promoters and the barriers to early initiation, and these among the caregivers of the children in that age cohort that I mentioned. So the study in terms of the methodology, we adopted a mixed method design where we had interviews at the household level. That's for the quantitative data that we did collect. And also had interviews with several groups, or I would call them stakeholders, from the sub-county, the county teams, and largely talking to CNCs and healthcare workers who are seeing these caregivers or these mothers at the facility levels for the qualitative data sets. And we also had a number of KIIs with specific stakeholders. So we got to interview mothers, we got to interview when I say mothers, it's the adult mothers, the young mothers. We also got to talk to grandfathers. We also got to talk to community health promoters in those focus group discussions, just to see their views around breastfeeding. So on the sampling, or if I would say the sample size and the target population, I mentioned we were talking to caregivers. These are the mothers of children 0 to 23 months, and we had a 2-stage in terms of the sampling design. We used enough or SMART to derive our sample size, where the first stage was to select clusters, and these were villages distributed across all the 7 sub-counties that we have in Kilifi. And the second stage in that process was to randomly select households that had been listed, and the eligibility was a household that has a child who is within that age cohort. So eventually, we targeted to reach to 928 households, and those were 46 point something clusters that we rounded off to 47 clusters distributed across our sub-counties that we targeted for this data collection. In terms of the results, we did manage to reach 940 households, where in these households, we managed to reach to caregivers of around 938 children. And you'll see for the age cohort, and that's across the age cohort, 0 to 23 months, we had around 30% of these children who are aged 0 to 5 months, which is around 281 children. Now, I will speak into the breastfeeding outcomes, which were of our key concern, and greatly to note, for early initiation, and this is the first column, we were at 70%, which is higher than the national level, which is, I would say it's a great achievement. And across the three indicators or the three outcomes that we looked at, the early initiation, which is in a child being initiated on breastfeeding within 1 hour, we were at 70%, which is above the national, which is 60. And then for exclusive breastfeeding, we want the children to continue breastfeeding for up to the age of 6 months, we were at 86%, which is also above the KDHS national outcomes. And still for continued breastfeeding, we were at 77%, which is also slightly above the KDHS, which is around 61%. Now, for the knowledge, and this specifically for caregivers, most of the caregivers that we spoke to, around 85% of this, they believe that a child should be breastfed immediately they are born, or a child should be put to breast immediately after birth, which is a good thing. And we will see how the knowledge among the caregivers, and I would also want to thank maybe the healthcare workers at the facilities for cascading the same. We have knowledge and we have caregivers that are aware of why breastfeeding is important, and most of them have a good opinion of the breastfeeding practices. Now, however, in terms of breastfeeding support, when a caregiver comes to the facility, delivers, and the intention of they want to be supported in terms of initiating breastfeeding, we had around 41% of caregivers that did not receive support at all. So we have great efforts in certain steps, and also we have other areas that we need to work on. Just to highlight the conclusions in 2-bit, connected to the high performances across the breastfeeding indicators, we would acknowledge the effort of the BFHI activities across the counties, where we have AYCN messages being passed to mothers from different forums at the facility level and even at the community level. And our intention in terms of the recommendation is for that to be sustained and to be cascaded to all the community health units. And you can see we spoke about the factors that are promoting the good uptake of breastfeeding practices, from health education, which is key, and also the sensitization that continues as mothers visit for ANC clinics. And in terms of the barriers, we have the lack of support, which came out clearly from around 41% of the respondents that we talked to. So those are recommendations. And maybe just to mention, the breastfeeding or the early initiation was okay at 70%, which we spoke about. But when you look at children that were exclusively breastfed, there was an issue. So we had exclusive breastfeeding that was okay, and it is in the first 3 months. When a child is 4 months, 5 months, and 6 months, the exclusive breastfeeding rates were slowly going down. So we would want to improve on that sector. Then the coverage of exclusive breastfeeding is good, but we are not yet at the 90%, which is recommended by WHO, and it's also seen to reduce the mortality that Prof talked about earlier on, and the scale up of the community health activities across all the units. I suppose my presentation ends there. Great thanks to my team at Helen Keller and also the county government that we collaborated in this study. Thank you so much.
Thank you, Ben. We need to confirm whether Husna Mwaka is here. Okay. Melanie Yolum. So you're next. Anyone who has a presentation within this session, please come to the front so we can save time. So, Melanie, please take it on. Did I hear a yes? I thought I had a yes. Oh, you're coming. Karibu. Anyone else who has a presentation, please come sit at the front so we can save time. Melanie? Yes, please. Take it on.
Good afternoon. My name is Abigail Sidi. Sorry for the miscommunication. I'm doing a presentation on menstrual health hygiene management. I am from International Center for Reproductive Health, Kenya. Yeah, good start. Okay, thank you so much. So our topic is exploring menstrual health and hygiene practices among adolescents 10 to 19 years. This was a national survey conducted in 8 counties across the 47 in Kenya. So, sorry, my eyesight is poor. Okay, this is much better. So, so we did a small introduction about who an adolescent is. For this study, we focused on persons between the age of 10 to 19, and we described MENAC as a biological milestone for an adolescent girl, and it marks the onset of the reproductive phase. So we know despite having a lot of potential, there is heightened vulnerabilities, especially in low and middle income countries. And in Kenya, the last study that was conducted, about 54%, with 58% in rural and 53% in urban, still face challenges in accessing MHH products. So this was our problem statement. We had a deep dive into the current documents that Kenya currently has. So we looked at the menstrual hygiene policy, the strategy, reproductive health policy, as well as the adolescent sexual reproductive health policy. And then also another challenge that we had in our problem statement was most of the focus is normally on menstrual hygiene, with a mismatch in the menstrual health component. And you see this is normally integrated into sexual and reproductive health and services. And then there's also limited understanding on the influence of MHM policies and programs on adolescent girls and their experiences. So these were our objectives. One, to just understand the menstrual health hygiene practices among adolescents, and then to review the extent to which the policies that we have in Kenya have been implemented, both in schools and within the communities and other relevant settings, and just look at vulnerabilities that adolescent girls face. So this was our methodology. It was a mixed method approach. We had a desk review to review the documents, and then we had a quantitative with a sample size of 1392 for the entire country. This one targeted adolescents using a household survey, and then we also had adolescents with disabilities taking 10% of the total sample size, and then we had both in and out of school adolescents. And then for the qualitative, we had IDIs, FGDs, and KIIs with adolescent boys and girls, parents and caregivers, teachers, hygiene promotion officers, reproductive health coordinators, and both county and national stakeholders. So this was the distribution in terms of the study geography. We were in those 8 sub-counties: Kitui, Garissa, Marsabit, West Pokot, Bungoma, Homa Bay, and Nakuru, representing all the 6 blocks in Kenya. And these are our findings. So averagely, the age to start menstruation for most of the girls was 12 years. And then in addition, 20% were between the age of 10 to 19. The majority, which is 49%, were between the ages of 15 to 17, and then the remaining was 18 to 19 years. And then at the time of the survey, majority were in secondary school, representing 56%. We had about 30% in primary level and about 3% in tertiary. And then of the total sample size, we had 10.6, which represented adolescents with disabilities, those with hearing, physical, and visual. And then in terms of knowledge of menstruation overall, 74.4 girls had prior knowledge of menstruation before they started receiving their monthly period. And then among those with disabilities, only about 53.1 had knowledge. So you can see the disparities when you compare adolescents with without disabilities and those with disabilities. And then most of the adolescents reported receiving this knowledge from schools. And in schools, we also went further to see if this education is provided to both boys and girls, or it's just for girls. So for many of the schools, 60% this education is given to girls only. And then about 29% give it to both boys and girls. And then we had about 8.9% reporting they didn't receive this kind of education in school. And then in terms of the practices, this is what we looked at. Mostly for the change of menstrual products was mostly at the pit latrines. And then frequency of change, majority reported changing thrice, but this was followed closely by adolescents who reported changing their products twice, and then we had once, and some for a very few percentage, more than 3 times. And then we looked at the access to water, the component of menstrual hygiene. So we asked if they had access to both water and soap. So this was below average at 45.3, the ones who reported having both water and soap. And then 30% had only access to soap but did not have water. And then another 23% reported they didn't have access to either soap or water. And then in terms of what most adolescents would use, majority said they use disposable pads, but again, they had difficulties in accessing them. And then we had other products that were used, such as pieces of cloth, and then we had underwear, panty, and also cotton wool. In some areas, like in Marsabit, we also had, and West Pokot, we also had adolescents talking about pieces of leaves and things like that, and blankets. And then overall access to menstrual products. So 54.4 reported no difficulty in accessing. This shows that we've made some strides from the initial study that was done, that was at around 45%. And then, so the difficulty in access was closely associated with affordability. So most adolescents said that these products are quite expensive. And then we looked at the health-seeking behavior. So adolescents reported receiving some menstrual health complications like heavy bleeding. We also had pelvic cramps and things like that. But of those who cited those, majority did not seek care. And the ones who sought care, only 35.3 are the ones who sought care from proper public health facilities. Yeah, so this I've already talked about. So the bigger bracket is the one that reported receiving pelvic care, though we also had adolescents citing excessive bleeding, back pain, and things like that. So the kind of management that was used was pain relievers, hot water. Some of them took a rest, it means missing school and things like that. And then we also looked at vulnerabilities now for adolescents regarding menstrual health and linking it to urogenital infections for those who use unconventional products. And then we also linked the same to transactional sex, because most of the adolescents also cited that these products were often unaffordable. Yeah, and then these are our recommendations to raise awareness, having multi-sectoral frameworks, also looking at gender mainstreaming and social behavior change communication programs that target adolescents and communities, and then strengthening the specialized menstrual support, especially for girls with disability, for us to have more inclusion. Yeah, and strengthening and sustaining the free sanitary towels that is already currently in our policies. Thank you.
Thank you, CD, and sorry for calling you by the wrong name in the beginning. Our next presenter is Margaret Hanselman. I hope I said that correctly. Okay, karibu sana, take it on.
Asante. Good morning. Margaret Hanselman. So I'm Margaret Hanselman. I hope that's easy on your tongue. From the Center of Excellence in Women and Child Health, a department within the Aga Khan University. So I was really hoping that the speakers before me would have set the ground so that I can skip some of my introduction, but unfortunately I'll have to start from the beginning. Okay, so I'll be presenting, I'll be presenting our preliminary findings on a research that is centered on adolescent health, especially mental health, and it was a co-design intervention being implemented in 2 countries, that is Mozambique and Kenya. So it has the acronym INSPIRE. So INSPIRE is, thought of when our PI was thinking of an intervention. Oh, sorry, when she was trying to, I'm sorry. Okay, I usually get a little bit cold feet when I start. So when our PI was trying to lay the foundation on how to, for the funding, there were two things that stuck out for her. One of it was adolescent pregnancy. So adolescent is a stage whereby of vulnerability, heightened vulnerability and transition from child to adulthood. And during that time also, these adolescents experience a number of changes, be it physical, be it physiological, and also at times it impacts the mental health. Then let's think about pregnancies too. So pregnancy is also a stage of vulnerability whereby a woman experiences a lot of changes, physical, physiological, and also impacts the mental health. So when in 2020, when this funding when this protocol was being written, Mozambique was 4th highest in adolescent pregnancy, while Kenya was 10th in absolute numbers because we have a high population of that demographic. And 1 in 3 of pregnant adolescents had experienced a mental disorder during pregnancy or the perinatal period. And we all know that mental health status of a mother also impacts either negatively or positively on the mother herself and also on the pregnancy outcomes. That is also the child. So it is said that we are expecting adolescent pregnancies in Africa to do what? To shoot up in the future. And when you think about interventions which are there, mostly when you think of interventions for mental health, not only mental health, but also in other spaces, you think about approaching the experts, either the clinicians or the researchers, right? But Inspire did it a bit differently. We tried and this is not a political statement, but I usually call it bottom up. So whereby we try and engage the community, and in this case, Inspire engage the adolescent girls who are our target group, the community influencers, and also service providers to help us co-design an intervention. So the aim of Inspire is to work with adolescent girls, their families and communities to co-develop and evaluate an intervention to improve adolescent perinatal mental health through human-centered design, systems thinking, and implementation science. So Inspire was done in 2 phases. The first phase, we co-developed the intervention, and the second phase, we evaluated the prototype that was developed in phase 1. So in all this process, we've engaged, here it says 163, but if we include also Mozambique, it's above 200 stakeholders. It was implemented between 20 and 24. And within this engagement, we engage adolescent girls, that is pregnant adolescent girls between the years of 15 and 19, young women, that is 20 to 21 years who had a child who was under 1 year old, meaning that she was pregnant during the adolescent period. And then we also engage their partners and their family members, service providers, both at community level and also facility level, and also the community influencers, like religious leaders, teachers, et al. So during this, using the human-centered design, we had iterative workshops whereby we, through qualitative interviews, photo voices, spiral walks, we got to know the gaps, the needs, and opportunities of these adolescent girls during the perinatal period. We also had interviews, focused group discussions, and also qualitative interviews, that is the KIIs with the service providers and community influencers, to get to know what their experiences are with pregnant adolescents. So from there, a number of themes came up. We generated a number of themes. And during this iterative workshop, we identified the priority themes which later helped us create the content and also the delivery strategy of the intervention. So the identified priorities were this. So there was the dealing with stigma when they were pregnant, getting good antenatal care, there was GBV, there was return to school, having good relationships with the family and their friends, knowing how to care for the baby, preventing future pregnancies, and also having enough money to pay for their essentials. Because remember, these are adolescents. Most of them have dropped from school. No one knows how to get money, how to get an income to take care of themselves and their babies. So these were the identified priorities, which were then designed to make up an intervention. We call it like an enhanced ANC intervention. Lord. So this is the proposed intervention. So in Mozambique, they call it Kutandizana, and in Kenya, we call it Malkia wa Malengo. These names were given by the adolescent girls. So Malkia wa Malengo is a series of 8 sessions, which is delivered by a mentor mother. So the mentor mother would take girls through 8 sessions, and there are group sessions where they're only the adolescent girls. Then there are one-to-one tailored sessions for the adolescent, an individual adolescent girl, and also the girls were allowed to bring a trusted family member or a friend during the group sessions. So we also did some referrals during that training. So this is, sorry, during the intervention. So this is the prototype intervention Malkia Malengo, which went to the second phase, which was the evaluation of the prototype. So the evaluation of the prototype was a mixed method, whereby we had a cluster random hybrid type 2 study. We had 80 girls, that is for Mozambique and Kenya, 40 of them in a control arm and 40 of them in an intervention arm. The control arm received all other ANCs services without the intervention, while the intervention arm received the intervention and also the normal services that they get at the facility. So I'll just give preliminary findings because we are not through with the analysis. So we first trained the mentor mothers. Remember, the mentor mothers for Kenya were picked from the CHPs, while in Mozambique, they picked them women from the community members. This was a criteria that was given by the adolescent girls. They're the ones who created the content of the intervention and also how it will be delivered. So during the 8 sessions, we collected data at 3 time points: at baseline, midline, that is at meeting 4, and also at end line, that is 3 months postpartum. We had to consider the 40 days. For most within the course, you have to take 40 days indoors after delivery. Yeah. So preliminary findings show that there was an improvement in anxiety and depression scores, because we collected also mental health assessments within this, the 3 time points. And this is what we found. For both Mozambique and Kenya, there was a reduction, 100% reduction of severe anxiety and severe depression. What did we learn? That when we work together with the community, we can effectively address mental health challenges. And then when we engage adolescents, it can lead to effective and sustainable interventions. And we need to engage all these stakeholders when we are planning for interventions, and also service providers see the value of engaging adolescents but need support on how to do this. I'd like to acknowledge our local advisory board who's been helping us. When I spoke about the systems thinking, they've been helping us to guide this intervention so that we can stay within the system. Thank you.
Thank you, Margaret, for being able to stick with the time as much as we're taking you really fast. So I'll welcome the other chair of the session to take it on from here. And yeah, she'll introduce herself.
Thank you so much, Nancy. Thank you all, the presenters and everyone. I don't know if Edna Rono, are you in? If she's not in, we can go to Linda Sanyana. Linda? Linda is from North Coast, but she's currently pursuing her degree in medicine at Pwani University. Most welcome. You can take on.
Hello everyone, good afternoon. My name is Linda. I'm from North Coast Medical Training College, and I'm also a student in Pwani University doing medicine. Today I'm going to discuss with you our research, our course experimental study that we did in 2024 on association of menstrual health products, provision and school attendance among adolescent girls. When we say menstrual health and hygiene, we mean having enough menstrual health products, being able to change the products, and having enough or a place to change the product at the right time, and also being able to dispose them at the right place. Sorry. Our study is important, particularly in Kilifi County. We have several studies that have been done on the same, on menstrual health and hygiene issues. And there are challenges that are facing girls. And several studies report that these challenges influence girls' quality of life and also their school attendance. UNESCO estimates that 1 in every 10 girls miss school during menstruation. And this is so significant because right now, or in our findings during our literatures and during our studies, there was a limited data on understanding specific factors associated with girls missing school during their adolescence. And now we aim to do an investigation on girls' perception and knowledge on menstrual health products and menstrual health issues, and also association of menstrual health product provision to school attendance. We did our study in Kilifi South Sub-County in 5 purposely selected schools, and we randomly selected 300 participants. Our study was focusing on school-going adolescent girls aged 14 to 18 years who had started MENAC, and they were mostly from low and middle-income counties, and families. We employed a mixed method approach also. And for cross-section study, we administered a structured questionnaire. For the qualitative study, we did focus group discussions to examine the perception of menstrual health products in different participants. For our post-experimental study, we provided menstrual health products, and we also administered a questionnaire in the beginning, that's baseline, and also at the end line. I want us to discuss more on our intervention. For our arm A was our control arm. Arm B, we gave them disposable pads. Arm C, we gave them reusable pads. Arm D, we gave them menstrual cups. And arm E, they were to choose from the 3 products. And for quantitative, we used Kobo Collect tool to collect, and qualitative, digital voice recorders. During our data analysis, we used Starter version 15. Quantitatively, we did descriptive analysis of medians, interquartile range, and frequencies. For inferentials, we used Mann-Whitney U-test and chi-square where it was appropriate. And for us to determine the change between baseline and endline, we used the Wilcoxon signed rank test to examine that. When you see our results on demographic of our participants, we had a median age of 17, and most of these participants were Christian with 83%. We had an interesting finding where 28% of the participants reported having their parents as source of information. We had another finding that 62% of the participants reported having abdominal pain during their menses. We also examined participants and on their likelihood to discuss mental health issues with parents, healthcare workers, friends, and teachers, and these are some of the findings that we found there. On our discussions and our results, the prevalence of mental health, we scored the knowledge score, and it was high across the 5 schools. But significantly, we had School D, I was supposed to know that. School D that had 3%, and School B that had 34% knowledge score. But to point to note, the prevalence of knowledge score was higher across the 5 schools. For us to determine the change of menstrual health at the baseline and endline, we used the Likert scale with an interquartile range of 1, where 1 is rarely miss school, very rarely miss school, and 0, never miss school. So during baseline, the interquartile range was 1 across the 5 schools, including the control arm, and it shifted to 0, that is never, in the 5 schools, even including the control arm. We will discuss more during our discussions. So on our perception study, we found out that disposable pads was the most preferred method, and participants reported that financial constraint was the limiting factor. Reusable pads was emerged as the most cost-effective because participants could use it more and more. Menstrual cups faced a lot of skepticism that there will be virginity loss and difficulty in insertion. So from our presentations above, we find out that most of the participants only heard about menstruation when they were in their MENAC, and as we noted earlier on, only 28% were getting information from their parents about menstruation. And these findings align with some of the studies done in Bangladesh. We also found out that reduction in absenteeism following provision of menstrual products across the schools, though it was unexpected, but it influenced that sufficient menstrual health product provision improves girls' school attendance. We had some similar studies done by the Hanenga and the group on the same. I want us to note on our findings on control change. It kind of reports that though we didn't provide the products to the girls, there was a shift in the school attendance, hiding out that behavioral shift can decrease by the participants being observed or when they are being watched or they are participating in a study. This can be done by Hawthorne's effect that was done in 2007. I wanted to know that most participants use disposable pads, but financial constraint was the limiting factor. This report highlights that economic limitations influence girls' utilization of the type of product. To conclude, a significant reduction in mental health products reports that participants have access to sufficient products when they can attend school properly. There is a need for enhanced mental health education from our MENAC study, and suitable menstrual products can help reduce school attendance. I appreciate all the sponsors and our supervisors. Thank you so much.
Thank you so much, Linda. Sorry for the pressure, but we are all getting to listen in and take note of all the questions. As you can note in our program, we've decided to have the questions at the very last bit. Next is Dr. Helen Nabwere. Most welcome. She's a principal investigator from Aga Khan University. Most welcome.
So good afternoon, everyone. So my name is Helen Nabwera. I'm a pediatrician, a physician scientist, and also associate professor in the Department of Pediatrics, but I'm also work in the Center of Excellence for Women and Child Health. So the work that I present here is part of the work that we do in the child health theme within the Center of Excellence in Women and Child Health. And within the center, we promote early career researchers, and one of them is Ms. Joycelyn Kathembe, who's currently on maternity leave. So she's been leading this analysis, but I'll present it on her behalf. This work is funded by the African Research Leader Fellowship, which is through the UK Medical Research Council, as well as the Foreign Commonwealth and Development Office, as well as the EU. So thank you. Thank you for the opportunity to present this on her behalf. Okay, so the presenter before me, a few presenters before me talked about stunting. And stunting, as we know, is where a child is too short for their age. The process is really called linear growth, and the process is actually called stunting. So the statistics that we often receive in the global reports on nutrition actually refer to a child being stunted, but there's a slight misnomer that they call it stunting, i.e. the process. Now, historically, we thought, those of us who worked in the nutrition field thought this was somehow an indication of chronic malnutrition. But we now realize that actually it's an indication of more than that. It's not just about nutrition. It's more around issues to do with both maternal health as well as newborn health status, but also all the other aspects around nurturing care that surround that baby once they're born. And so this is just really a map of the current status of stunting worldwide. We have a global target of reducing stunting to about 100 million by 2030. However, at the moment, there are 150 million children who are stunted, and the numbers, instead of shifting down, seem to be static or going up in some countries. So in sub-Saharan Africa, the numbers are going up. The presenter before me as well talked about the fact that Kilifi County has one of the highest rates of children being stunted. And so therefore, doing this piece of work in Kilifi is really critical in terms of really addressing some of the challenges that we have in bringing these numbers down. So this is a global chart of somehow where we are globally. And as you can see, in Kenya, it's not yet dark green as some of the other countries, which often represent countries where there's a burden of internal conflict. But the rates in Kenya are still unacceptably high. So overall, about 18% of children in Kenya will be stunted. And then I'll highlight the Gambia as well, which is a small strip of a country in Western Africa within Senegal, where the numbers there also are very high. And I'll explain a little bit more why I focused on these two countries. Okay, so as I mentioned before, we used to think being stunted was an issue of chronic malnutrition. But now we are beginning to understand that there's more to it than that. And so our group looks a lot at newborn vulnerability, just to see, not just, we focus on aspects of mortality, but actually, as the quality of care in many of our settings is going up, more of these children are beginning to survive. Now, when you look at survive and thrive, in approximately, as I said, overall, approximately 1 in 10 babies will be born low birth weight. Those are babies who are less than 2,500 grams. And the reason we focus on them is that for a long time, WHO has used somehow that measurement as an indicator of vulnerability, especially around mortality. But there's a greater realization that when these children survive that neonatal period, they're the ones who are at the greatest risk of being stunted or having impaired neurodevelopment. So there's a very strong association between a child not having proper linear growth, i.e. stunting, and impaired neurodevelopment. However, in 2022, a group of experts led by Professor Per Ashon and Prof. Marlene was also involved in that, really wanted to think again about the vulnerability in the newborn period. And so there was this newer conceptualization of the fact that, yes, indeed, low birth weight refers to babies who are born small for gestational age, or those who are born preterm. However, there are also groups of children who are born preterm, but greater than 2,500 grams, but still have significant vulnerabilities, both in the newborn period and beyond that. So the reason I present somehow both of these concepts are because we've included them both in terms of our analysis on predictors of impaired neurodevelopment and stunting. I'm struggling with this. So the aim of our work was really to evaluate the predictors of stunting or impaired neurodevelopment in the first 2 years of life. And thankfully, when we arrived here, we had found that there was a pregnancy birth cohort called the Precise Diet cohort, which is led here in Kenya by the Aga Khan University. And this pregnancy birth cohort has over 4,000 women and a similar number of newborns. And so we used this pregnancy birth cohort to conduct this analysis. Okay, so just really quickly going through the methods. The reason why we use this cohort was because it's really what we call deeply phenotyped, as in this really enhanced characterization of all the exposures, both in the antenatal period and the postnatal period. And we were really interested to understand what possible exposures could predict poor outcomes in terms of both linear growth as well as neurodevelopmental impairment. And for this, we used linear mixed models to try and characterize that. And as I said, the time points that we used were both antenatal and postnatal because of the work that had already been done ahead of us. And so what did we find? Just really quickly as we wind up, what we found was that when you looked at children who were normal birth weight, which is somehow the black line is the overall. The green line are those who are born with a birth weight over 2,500 grams or over. We found that, yes, indeed, you know, when their length for age Z-score, which is a measure against the WHO growth reference standards of how tall that child is according to their age, that they were approaching 0, so which is median, which is fine. But over time, by the age of 2 years, they had gone downwards, which means these children are tracking downwards. They are faltering as they go along in that period. And when you looked at those who are low birth weight, you found that they started off low, and there appeared to be some level of improvement, maybe up to about in the first year, but then, gradually they dipped off by the age of 3 years. But so this is somehow our, you know, the mark that we were looking at. But because the data tracked up to, sorry, I'm going to go back a bit. By the third visit represents the age of 2 years. And so you can see both groups were not doing well at all over time. And so just quickly looking at what the predictors were. So low birth weight was a key predictor of it increased the risk of neurodevelopmental impairment and stunting threefold, and that was very similar to when babies were male. So those were the key predictors. As you note, we looked at all these other different factors, but really nothing came through as being important. And then just as I quickly wind up, when you looked at the other conceptual framework of the small and vulnerable newborn, we found that infants who were classified as small and vulnerable, again, had a markedly increased risk of stunting as well as impaired neurodevelopment by 2 years of age. But all the other factors, there's nothing else that really came through. So what are we doing next? We are planning to do further exploration of the group specifically that we've identified, i.e. those who are low birth weight and small for vulnerable newborns, to really look at what the resilience factors are to determine somehow, you know, what we can do in terms of designing interventions to support to promote better growth and neurodevelopment in that group. And then just really in summary, as I finish off, the key predictors of impaired neurodevelopment and stunting are being low birth weight, and being male, as well as being small and vulnerable. So thank you very much. Just really acknowledging everyone who's supported me in this analysis, as well as the wider Precise Diet group led by Prof. Marlene and Dr. Angela Koech and Prof. Stephen Van Donaldson. Thank you so much.
Dr. Helen Naboer. Thank you. I hope we are all still taking notes of all we are hearing here. I think we'll need to change the name of this place to Fountain of Knowledge. Yeah? Coming next is Emma Nganga. She's a PhD student, also affiliated to Aga Khan University. Take it on.
Thank you. Good afternoon. My name is Emma Nganga from Aga Khan University, and it's a privilege to be presenting my work today on stakeholders' perceptions on AI-assisted pregnancy ultrasound across Rabai sub-county in Kilifi and Nairobi. So as Professor Marlene was saying earlier, MMR, or neonatal death rates, are still very high. And sub-Saharan Africa is actually bearing the highest burden. Most of these deaths can be prevented if only women could be able to access ultrasound services. And WHO recommends at least one ultrasound service for every pregnant woman before 24 weeks as care. And one of the importance of this ultrasound is to estimate GA and as well as detect complications early. But this is still a challenge in our low resource settings, especially in Rabai, because out of 17 government facilities in Rabai, only one, Rabai Sub-County Hospital, offers ultrasound services. It's also very expensive because of the socioeconomic status of these women. The myths and misconceptions around ultrasound. It's also expensive to procure this machine. And so the question we are asking ourselves, how can we make it possible for these women to access ultrasound services wherever they are, regardless of where they live? And that is where our project comes in. Our project is called IMIX. It means, it stands for Inclusive Artificial Intelligence for Accessible Medical Imaging across resource-limited settings. And what we are doing is we are designing a simpler way of assessing pregnancies using artificial intelligence And this can be used by our local nurses, in local dispensaries. Sorry about that. So as opposed to the standard ultrasound scan, which needs expert, nurses in our local dispensaries can be able to use this. As you can see from that picture, this is a nurse holding a probe and a tablet, and that is the device we are talking about. We are currently in the design phase of this model, and we will have a low-cost device, which will be portable. It will use battery instead of electricity and can be used by our nurses in our dispensaries. Most importantly, we want to ensure that this technology fits the local context, even as we talk about the theme of this conference, which is UHC. And so how exactly are we doing this? AMIX has 3 objectives, and number 1 is to develop this model. Number 2 is to validate the model, which we are hoping to do sometime in the 4th quarter of next year. And what we have done is the qualitative component, where we want to explore the needs and the perceptions of this innovation among stakeholders. So how exactly did we do this? We conducted semi-structured interviews and focus group discussions with 84 participants across Nairobi and Kilifi. And the people we were talking to included pregnant women, sub-county health management teams, CHPs. And this is actually amongst the first study to even include the very grassroots community members like village elders in artificial intelligence conversations. So what did we find out? There is optimism and there is hope that this technology can actually improve care. But people are still asking questions. How will my data be used? What if someone misuses this device because it's very portable? What if a clinician finds something and they don't understand how to interpret it? So there are so many concerns going around. And this one is just reminding us that it's not just about algorithm, but as we're building technologies, we have to ensure there's trust and there's transparency. So we also realize there are some potential barriers to implementations. One of them is the myths and misconceptions around ultrasound and technology in our rural settings. There's also high illiteracy levels, male-dominated healthcare decisions. And what we are hoping to do, and we're actually already doing, is trying to find ways to mitigate these barriers so that even when it comes to implementation, we can be able to implement it successfully. So in the last 2 years, we've done about 67 community sensitization, and we're including men in this conversation so that they can be able to understand it and support us. We are also hoping to train healthcare providers so that they can be able to use this technology when it comes. And we will do validation, as I've said, the 4th quarter of 2026, and also health system support. So what this experience is actually teaching us is that for technology to be truly effective, it has to connect with the people that it's meant to serve. So it's no longer about just algorithms and just building technologies, but for us to have technologies or innovations that are inclusive, that are trustworthy, that people want to use, then we have to bring so many stakeholders on the table. So they have to have a stake on the table. And so we cannot just design technologies for people, but we have to include them while we are designing these technologies. That picture is a picture of our community advisory board. It's made up of community members, healthcare providers, CHPs, members of the community who will be helping us co-design this technology so that we can develop a technology that is contextually relevant and is wanted by the people. Appreciation to everyone who's been part of this project, especially our participants and communities for their insights, Kilifi County staff, and everyone for listening to me today. Thank you very much.
Thank you very much, Emma, for saving us a minute or two. I will invite my co-host, Nancy, to take us through the Q&A session.
So thanks so much for sitting in through some of the time for lunch, but a quick question is, rather a quick request is to just have 3 burning questions. All the other questions can be addressed by just following the presenters. Anyone with a burning question, please? Yes, no, maybe? I don't know. Can you repeat the question? Anybody, please? Okay, Charles, should we hand it over back to you? Please follow the okay, one question.
There's a question.
Burning question, okay.
Good afternoon, everyone. Maybe to ask, I was concerned about the guy who presented about the breastfeeding. Pole sikuweza ku capture the name. I think he was the second presenter. Benjamin. Okay. Benjamin was doing study about the breastfeeding, and he was doing a qualitative study in terms of SDGs and KII. And the numbers of household that he was able to capture was 900 and something. So I was just asking myself, the number, there was no a good presentation on the number of the sessions that were performed, the KII and the G that were performed in the house, the number of the household that were performed, that is 966. Maybe that one could be elaborated for the further understanding. For the Abigail, good presentation, but we were struggling to see the color and the size were a bit, so we were really struggling to see. And then the final one, to the Daktari from Coast what? North Coast. There were 5 schools that were selected, 5 purpose-free sampling school. I would wish to understand this purpose-free, the word purpose, why were they selected? And then I would wish to know the outcome of this study. Was it about the school absenteeism or what it's all about? And if it was about the school absenteeism, was he considering about the confounding factors? Thank you.
Can we take another one?
Good afternoon. I have one question to Benjamin. It's just a concern or rather a comment. You presented very well. However, when you look at one of the references that you made, that was from Lancet of 2003, we understand that is that long time ago and things really have changed. Maybe you can improve on the when you are doing citation, because 2003 really is a long time, and we understand that things have really changed over time. I have a question to the lady. Pardon, I didn't get your name, but she presented on Association of Medical Products, Ministry of Products. You see now, when you took through the presentation, there were things that are expected, because when you talk about association, we need to see, some kind of statistical relationship between variables. You talked about, we didn't see any relationship in that. However, you could see some p-value that was set. We were not shown what significance level did you set for this p-value and the outcome variable, like what was the outcome. You only showed us the frequencies, but you don't know what were you really looking at, so that you can be able now to follow through to the latter. The last question is for Dr. Helen. She did the evaluation on the predictors of standing and all. I didn't get the whole capture. Again, we didn't see those independent variables that we are talking about. We only saw the multivariable results, whereby we know in terms of the flow of statistics, you start from, basic advancing, such that by the time you come to the multivariate logistic regression, we have already seen at bivariate level, what were you able to say at the significance levels, such that these significance levels at bivariate, now you are the one now going to take them to multivariate logistic regression that can be able to see now what are these associated factors to the topic, or rather to these standing factors that you are addressing. Thank you.
So, thank you. I appreciate your comment around the citations. That's well noted for improvement. But to mention on the gentleman who spoke first, I guess I spoke, the 900 and something you are talking about was numbers specifically for the household survey, which is the quantitative section. However, I did also highlight that we talked to a number of groups, from young mothers, adult mothers, the CHPs, and that was through focus group discussions. And that data was probably missing, but we had targeted those groups in all the 7 sub-counties. So for instance, we had an FGD for adult mothers in each of the 7 sub-counties. We had an FGD for young fathers, an FGD with CHPs across the different sub-counties, only that data was not presented. Yes, KIs, we had KIs with the groups that I mentioned. We had partners from the development partners, and we also had KIs with government officials and health workers at the health facilities. I guess that was missing, but that data is available. Thank you.
Thank you. My first answer is to the person who asked about purposive selection of school. Here, we meant the schools were not supposed to be like close, so they were supposed to be 5 kilometers apart. They were supposed to be public schools because assumption says most of them are from the lower income countries, and also the schools were supposed to be, most of them, they were mixed schools, so they were also supposed to be mixed school. Another question was on what was our outcome. My title was association. So our goal was, is there a lowering or a reduced school attendance if we provide menstrual health products across the 5 schools? And as you saw in our results there, we said there was a significant reduction across the 5 schools, where in the baseline, the participants rarely miss school, then in the end line, they never miss school. That was the goal finding. The second question was from significant value was 0.05. Still the outcome variable was the same that I've answered. I don't know if you have another question. Yes.
So thank you very much for that comment. The reason why we didn't include the univariable analysis in this presentation was because it would have been a very long presentation. So as I said, this pregnancy birth cohort was really deeply phenotyped. They looked at really multiple factors, almost about 100 or more than that. And so we really had to distill down and somehow group some of them. So we will include all of that in the manuscript that we are developing step by step. But essentially, as I showed you, it's a wider group of people who are conducting this analysis. And for in the univariable analysis, any variable that had a p-value of less than 0.2, we included in the final model. But also we looked at what's clinically relevant, or what's going to somehow make sense in terms of relevance as a predictor of stunting or impaired neurodevelopment. So it's a very large data set, but look out for the paper. We'll include all of that in that. Thank you for that question.
Asanteni sana. We had one last presentation. We will really shorten it up. We were considering not having it today, but it's really going to be very short. So just let's have it go on, please. Philomena, take it on.
Okay, good afternoon. I am Philomena Munga, and I'm going to take us through improving neonatal outcome in Kilifi County, a case study that we did it in Kilifi North, and more specifically, Kilifi County and Referral Hospital. And we did that together with Elizabeth Omondi, Uzazi Salama, at the same time with the sub-county health management team support, and Kilifi county and referral hospital management. So my presentation will have the background information, interventions that we implemented, the key findings, and lessons learned. So we have seen quite a high maternal mortality rate of 532 per 100,000 live births, compared to the national that was at 355 per 100,000 live births. That was KNBS 2019, while the neonatal mortality rate was at 24 for Kilifi County, and compared to the national of 21. And that is KDHS 2022. In 2024, we noted that Kilifi North Sub-County was having the highest contributor to the neonatal mortality rate, and that was at 22 per 1,000 live births. That is a facility rate, and perinatal mortality rate of 26 per 1,000 live births. And this data was from the Kenya Health Information System 2024. Kilifi North Sub-County recorded 115 fresh stillbirths during that time, and 135 macerated stillbirths. We also noted that we had a total of 230 neonatal deaths. We're talking about the deaths of 0 to 28 days. In the financial year 2023-2024. Kilifi North also noted a very low auditing rate. For both perinatal, we were at 0%, and neonatal, that we were at 3% of the deaths that were reported during that time. And looking at that, we noted that the sub-county was having a sustained high burden of mortalities, which was coupled with either delays in or incomplete death reviews. So what did the sub-county do was we went down to form a task force through the support of the health management team lead, Dr. Bilal. And our main aim of that was to look into what is causing the low auditing rates and having an objective of increasing those proportions of perinatal deaths and neonatal deaths audited in Kilifi North from this 2% to 50% by September 2025. We also needed to improve the quality of the maternal perinatal death surveillance and response data in Kilifi North, because we also noted that there was some data that was left out from some department during reporting time. We had to strengthen the capacity of the MPDSR team, and we also needed the champions to be capacity built in Kilifi North. So what did we do? We first of all went into data desk review. We also went in to look at whether we have the structures that were needed. And we realized that the structures, yes, though we had a team, but did not have terms of reference and did not have letters of appointment. So the irregular reviews and the no reviews in the perinatal deaths. We also didn't have anybody who was championing that in the departments. And we noted that there was also an issue around the indicator definition. Some were reporting fresh stillbirth and ending up reporting them as macerated stillbirths. So we had to do the following. we developed a schedule of activities, and that is the weekly line listing and notification. We had to develop a line list that we did not have in the system. We also did schedule for weekly meetings, that is on Thursdays. So we had to also invite the people from the rural facilities who had referred those clients to us. We did weekly audits on the same Thursday. And we also had scheduled facility review meetings monthly and sub-county MPDSR review meetings. I've already talked about what we did about the indicator definition. We also did conduct data quality audits. We were comparing what was in the line list, what has been uploaded into the system, and going back to ensure that whatever it is that has been reported is what is in the system. So we also held data review meetings and linked these key findings we found to key interventions. And these are some of the interventions that we did. For the community-related issues, we did community feedback meetings. And on the side, we are seeing a community feedback meeting that took place in Matsangoni after we realized that there were some issues around mothers having stayed at home, delayed at home because they went to be massaged by TBS. We also did implement evidence-based mentorship out of the skills gap that we realized. Through partners, we managed to do mentorship on newborn resuscitation, mentorship on continuous positive airway pressure machine use. We also did mentorship on PPH or postpartum hemorrhage and management of pregnancy hypertension. We trained EMT on emergency response. We also ensured that because mother did not have routine blood checks, we ensured that we linked or leveraged on a lab network, sending a lab station to the maternity open days where we were grouping mothers and mothers with maternity open days. We supported quality qualification and forcing. We also celebrated our achievements. And this is what we had. We were able to move from auditing 9% in Kilifi County and Referral Hospital to auditing 100%, as we are seeing by September 2025. We managed to improve documentation. We designated a HRO and who was a champion to uploading this data. We also had a subgroup that daily communicates what is going on, including the line list and the report that we make after the review. We make actions and we communicate it to everybody after the review. And this was able to account for all the deaths that were happening in the facility. We are also seeing the same being replicated in the Kilifi North Sub-County, and we are now seeing the outcome. At Kilifi County and Referral Hospital, we were able to have a reduction of the neonatal mortality rate, facility rate, from 50.96 to 46.4. The fresh stillbirths ratio from 32 to 25%. I mean 25 per 1,000 live births. And this is what also translated into the Kilifi North neonatal mortality rate. We are seeing a reduction from 29.13 to 26.75 of the per 1,000 live births. So we learned that structured and evidence-based MPDSR process, supported by regular data death audits, are substantially improves documentation, strengthens accountability. We need to institutionalize the 6-step MPDSR, ensure that the findings are translated into response and data-driven action. We need to link this information into the maternal health outcomes that we have, and we also link it into the community linkages and facility linkages. Thank you so much.
Thank you so much, Philomena and Uzazi Salama team, for the good.
Each of the plenary sessions will be dotted with best practices, so we are happy to see what the team is doing in Kilifi North Sub-County, so a big hand to them as well. We're now going to break for lunch, and I want us to agree and be on one on this, that we cooperate to make sure that we claw back on the time that we have lost. So far, I know we are all enjoying the presentations, but I really would urge you, it's 2 minutes to 2 o'clock, but I really urge you, we have increased the serving stations, so if we just leave here straight to go to the serving station, and if we are able to be seated by 5 minutes to 3. 5 minutes to 3, and this is to Dr. Marianne Dawinkle, and who will be chairing that particular session, and Noni, who will be rapporteuring. We'll have 4 presentations on health financing. That's our second plenary, and we'll have a spotlight conversation by USAID. So please, if you would cooperate on that 5 minutes before 3, let us all be seated, and we will be ready to begin. Bon appetit, everyone. County here, represented by Honorable Joshua Jarha. He's a County Executive Committee member from Tana River. Mheshimiwa, just wapungie mkono tu kidogo hivi. Salamu nyingi kutoka Tana River, and of course Tana River is part of the larger Jumuiya counties of Pwani. Without further ado, allow me to invite Dr. Marianne from North Coast, one of our very good partners at Kilifi County, to take us over to the second plenary. Karibu Daktari.
Yes, asante sana, Charles. Yes, good afternoon, everybody. And also on my side, thank you very much for being very timely. I've been told we really need to keep up with speed. So I have one request that I want to make, just like the predecessors, the people who are presenting, who are only 3 in this session, if they can also move forward, so that when they have to present, it's easy for them to come. So Karibu, please take a seat here. Otherwise, it's my pleasure today to chair this session, which maybe you might disagree, but I think it's the most important session, because we always think, where is the money coming from? And we had earlier today, we were having I think already a remark from, I think, Dr. Noel, healthcare is not free. Even if people say the services are free, but somebody somewhere is paying for it. That's often where the shoe pinches. I remember one of my colleagues saying that we need to know as medical doctors or healthcare workers more about procurement, about HR, about financing. Other people said, no, you have specialists for that. But I think it is important that as people in the field, we really understand about this financing. It's where everything comes back. So I'm very, very pleased to chair this session about financing of universal healthcare access. And I hope we'll learn a lot. The word chief has already fallen many times. Maybe it will fall a few more times. So it is therefore my pleasure to, first of all, have our keynote speaker to share with us on that particular topic. I think I can read a little bit of his resume. He is called Professor Edwin Barassa. When you think of professor, you think of somebody very old, so don't be mistaken when he stands here. He's the Executive Director of Camry Wellcome Trust Research Program. He heads the program for the program's Health Economics Research Unit, and he's also a visiting professor at Oxford University in, also for health economics. He's interested in health financing, equity, and efficiency analysis of healthcare, of doing economic evaluations of healthcare interventions, measuring health system performance, and health systems governance. He has years of experience in practice, advisory, and conducting health economic and financing research in Kenya and in the broader Sub-Sahara region. Edwin, karibu sana. I think we can learn a lot from you. Asante sana for accepting today.
Good afternoon, everyone. It's a real privilege for me to be here, and contrary to popular belief, I actually feel quite old. And because of that, I might not be able to see what's on this screen in front of me. So I was asked to talk about health financing, to give a keynote speech about health financing. And the idea was me to, to give a broader view of how financing is done in the country and, county level imperatives to set the stage for the discussions or the presentations that you're going to have after this. But I'm going to give a variant of that discussion, and it's reflective of my observations over time. I say this because it's very easy for us to have a conversation here about, what's not working and which health financing reforms or recommendations we need to put in place. And then we wind up the session and say, great job, let's go and implement it. And oftentimes counties will say that, we are actually already doing those things that you're telling us are good to do. So my reflection over a period of time has been on why policies work or not, because I feel like we know solutions to the problems we have. What you're not very good at is ensuring that they actually work on the ground. So that's what I'm going to talk about. And if I am stopped before 15 minutes are over, as I've been promised, this is what I'm going to talk about at the end. This is really the message. That my reflection on why policies work or do not work is very obvious things. One, effective policy design. Policies should be designed based on first principles, common sense. First principles that ensure that a policy is linked to the intended outcome. So that's really quite important. So policies fail because often whole or part of the design are just not fit for purpose. The other is policy alignment. And by policy alignment, we are talking about the policy is a very big word for many small parts of it. So when we say health financing, for instance, or when we say facility improvement fund, or when we say SHA, SHA is not one thing. SHA has revenue collection arrangements, has pooling arrangements, has purchasing arrangements. Under purchasing arrangements, you have how you deal with providers, you have how you pay healthcare providers, how you contract them. So policies have many design attributes that could vary. And the idea is that you have to ensure that the design attributes of policies are aligned to health system goals. And so what are the desirable health system goals? You can define them. I like to define them as equity, efficiency, coverage, quality, financial risk protection, and so on. So when you're designing a policy, you need to ask yourself, is each and every of the design attributes aligned with the desired health system goal? Is the policy designed in a way that its attributes or its characteristics will incentivize or promote health system goals? That's really, really quite important. Then policy coherence. And policy coherence is really about ensuring that policy design is consistent with other enabler policies. Because policies do not occur in a vacuum. So if you say you are introducing a policy to improve access to care, but then the citizens are very far from the facility, then you have a problem. So you need to ensure that the design of your policy is consistent with other enabler policies. What are the other things that are required for the policy to actually work? Otherwise, what is likely to happen is that you will have a great policy or a great reform intervention that is then counteracted by other existing policies. So policy coherence is very important. Health system reforms, or rather taking a whole system reform approach to health policy is quite important. There are no silver bullets in health policy and systems. If you want to reform a system, identify the problem, design the policy intervention or reform, but ensure that you are using a whole system approach. You are looking at the problem from the multiple facets of the health system. Otherwise, again, it's going to fail. And then lastly, policy capacity. Does the system have the capacity to implement the policy or the reform that you are introducing? Because you can have a fantastic policy, but the system does not have the capacity to implement it. And by capacity here, I mean political capacity. So for instance, is there political feasibility? Is there political support for that policy? Do the actors within the system, the health system managers, the health system leaders, other stakeholders, do they have the skills necessary to navigate the political landscape for introducing the policy, to convince all the players in the system to ensure that the policy is actually passed in the county assembly, for instance, and implemented? So political capacity is very important. Technical capacity is important because it informs the design and implementation of the policy. Operational capacity, you can have political feasibility, you can have technical capacity, but you don't have the operational infrastructure to implement a policy. So you can design a very, very good provider payment mechanism, but the provider payment mechanism, its success relies on having very strong information systems. And if the information systems are not available, then your nice provider payment mechanism is not going to work. So political capacity, technical capacity, and operational capacity are quite important. Then, of course, resource capacity. You need resources, the required resources, to deliver on the policy. So if you forget everything else, just remember this slide, that as you think about improving healthcare in your counties, as you think about coming up with reforms, coming up with policies to improve healthcare and health system performance in your counties, you have to have these things in mind. Are you designing these reforms using first principles, common sense? Or are you ignoring them and saying, this county will be different? Do you have policy alignment? Are the characteristics of the policy or the characteristics of the ingredients of the policy, are they aligned to equity? Are they aligned to efficiency, to quality, to service coverage, to financial risk protection, and so on? And then ensuring that you're taking a whole system view of things. And lastly, ensuring that you're aligning your policy design. You're selecting policies for which you have capacity. And if you don't have the capacity, you're investing in developing that capacity. Otherwise, the policy will fall flat on its face. So I'm going to try and illustrate this over the next couple of meetings. And I'll illustrate this using a project that we did and concluded sometime last year, known as the Exemplars in Primary Healthcare. And the idea for this project was really based on this assumption that the quickest way to make progress is to identify peers that have been successful at something, learning from that success, and then transferring those lessons into your setting. So that was the premise on which this project was founded, and the project focused on primary healthcare. And the idea was to identify countries that have done very well in primary healthcare, get lessons from them, and transfer those lessons to settings that are trying to improve their primary healthcare. And we went through a whole process of identifying low and middle income countries that are doing well in primary healthcare, and we identified 5 countries: Zambia, Ghana, and Rwanda in Africa, and Peru and Bangladesh outside of Africa. So these are low and middle income countries that outperformed their peers in primary healthcare. So they were doing much, much better for the resources they had because they are low and middle income countries compared to the other countries. And then we used mixed methods to try and really understand and unpack what are these things that these countries were doing that have led them to improve primary healthcare performance. And we identified that these countries were able to make progress, substantial progress on primary healthcare by using 3 key pathways. One is that they were able to improve the level, the flow, and allocation of financial resources. 2, they were able to install strong performance management and accountability mechanisms. And lastly, they were able to improve access, readiness, and utilization of services. So these are the pathways through which these countries were able to improve primary healthcare performance. And so we went on to understand, well, for each of these pathways, what specific reforms did they implement? And we found that across these 5 countries, there were 18 reforms, or what we call drivers, that were common. And they are listed there, and I will not go through all of them, but I will just highlight political prioritization of PHC was quite important, sectoral coordination and multi-sectoral action, strategic purchasing, subnational and service level autonomy, so FIF in the course of the equivalent of FIF in Kenya. And then we also have equitable financial risk protection, so scaling up a financial risk protection mechanism that is equitable, and also thinking about expanding the health infrastructure. So 18 reforms. And for each of these, there were a couple. I'm going to focus on only 2 of them. So for each of these, there were a couple of specific reforms. So in pathway 1, for instance, for political prioritization of PHC, countries increased allocation of funds to PHC. They included PHC services in their benefit packages, and they managed to coordinate donor funding at the national and at the country, or at the district level, the equivalent of counties. So they had pooled funds. They had, of course, subnational autonomy, and they invested a lot in sectoral and multi-sectoral coordination. Under pathway 3, which is around improving access, readiness, and utilization of services, I'm going to highlight equitable financial risk protection, which is really around scaling up population coverage with prepayment health financing and targeting services to the poor. So being intentional about identifying the vulnerable in society and providing coverage to them. So what was the observation from this project? That exemplar countries did not implement unique policies. Whatever they were implementing, I'm sure you've heard the things I've talked about. Whatever they were implementing are things that were also implemented by non-exemplar countries. which begs the question, why did these policies work in those countries and not in the other countries? And that brings me to the 5 things I talked about. That in these countries, there was effective policy design. And to relate that to what we know, one of the policies that was implemented is social health insurance. Now, in Africa, we've analyzed social health insurance and found that it doesn't do very well. Only 4 countries have coverage above 20%, which means the policy is really not working in Africa. But then when we look at other low and middle income countries, we find that contributory health insurance or health insurance can work. So there are countries that have been able to achieve very high coverage with health insurance. And yet in Africa, it's not working very well. And part of the policy design that made this work is the fact that health insurance in these countries are predominantly tax financed. So it's a policy design issue. While health insurance mostly, in most African countries, is reliant on contributions. So policy design matters. Another illustration is back to health insurance, where when you look at the blue bars essentially outline population enrollment or coverage as at June of this year. And among the formal sector, coverage was 100%. Amongst the informal sector, coverage was about 51%. But then when we look at active coverage, those that are actually contributing, then among the formal sector is 93%, but among the formal sector it's only 20%, which means that is struggling to get the infrastructure design issue. There is policy alignment, aligning policy design issues with health system goals. The countries that did well in health insurance were able to align social health insurance with equity goals by providing subsidies for the poor. And these allowed these countries to scale coverage. So when you look at those 2 plots, that's Peru and Thailand, you see significant increase in coverage. And that increase in coverage is really accounted for by the red arrows, which is really just the government allocating funding to cover the poor. So African countries will not be able to scale coverage unless they allocate funding, government allocates tax funding to cover the vulnerable and the poor. Policy coherence. One of the ones that we just concluded doing is looking at an assessment of the Facility Improvement Fund in Kenya, FIF. And we found that FIF improved basic amenities in hospitals, but not in facilities. We also found that FIF did not improve medicine availability, but we found that it improves availability, utilization of maternal services. Why? FIF does not improve basic amenities in primary healthcare facilities because primary healthcare facilities do not have a lot of wiggle room for mobilizing resources, because they do not charge user fees and they also do not get county budget allocation. The county purchases, takes care of its inputs. So autonomy is not useful, very useful when you're not also giving them the resources to be autonomous over. FIF did not result in an increase in medicines because while counties have been given autonomy to manage their finances, they do not have a lot of autonomy in procuring medicines. So again, they cannot make any change there. We also looked at the impact of primary care networks across 12 counties, and we found that primary care networks did not improve service readiness, did not improve utilization of services. Why? Because one, there was no functional integration. The idea of PCNs is that you should network facilities, which means you should network the functions. So if you're networking on paper, but not networking the actual health system functions, financing, HRH, commodity supply, and so on, then the network is not very functional. And the other reason is inadequate primary health care foundational capacity. Before someone rings the bell, I see they want to ring my bell. Inadequate PHC foundational capacity. That while we want to improve PHC by networking the facilities, when we look at facility readiness, and this data is from the latest Kenya health facility assessment, we find that there are significant gaps in facility readiness. if you do not have drugs in the facility, networking them is not going to be useful. So you have to invest in capacity for policies to work. So why do policies work or not work? Effective design, policy alignment, policy coherence, taking a whole system reform approach, and policy capacity. Thank you.
Yes, thank you very much, Dr. Edwin, for that great presentation. I think you've shocked at least half of the area here when you showed your last slide on that that you could not find any evidence for PCN. So I think it's a serious issue to talk about. Thank you very, very much. I think we'll have some questions at the end of the session. I think for the sake of time, I would want anybody who has a question for Dr. Barasa, also please raise it together with the other questions. Then I think we are going to have 3 presentations, also in the same domain. And I want to ask Dennis Mwambi if he is around. Sorry? He's on Zoom. Aha. Okay, so who will help? Dennis Mwambi is presenting to us a study from evidence to action. The impact of advocacy toolkits on health financing in 10 Kenyan counties. So if he is on Zoom, then I need technical support. Financing in 10 technical support. Financing in 10 technical. I think I'm hearing myself. Meanwhile, I think we go to the next and we give time to set up. Is Philip Mazaulo around? Yes, thank you very much, Mr. Mazaulo. Mr. Mazaulo will present to us on empowering counties for sustainable TB HIV program ownership, findings from Kilifi County transition baseline assessment. Karibu sana.
Right, thank you. Good afternoon. If you can see me with one eye, 2 eyes. I know we are presenting after lunch. My name is Dr. Philip Mazaulo. I work with the USIG Stawisha Pwani, the Deputy Chief of Party. My background is Masters in Public Health and of course an undergraduate degree in medicine. I'm going to present to you recent findings we carried out here in Kilifi County in terms of their readiness for transition. And I think, as you are aware, you have seen last week those signing an agreement between the US government and Kenya in preparation for transition. And therefore, our interest here was to see whether, when it comes government to government funding, then Kilifi County will be able to administer the funds. So in terms of background, globally, there are over 26 million people who are living, who are on ART, and about 7.6 million babies who have been averted from getting HIV through the PMTCT program. In Kenya, we have more than 1.3 million people, and in the last 5 years, there has been a decrease in funding of HIV programs. Globally, in Kenya, range between 10 and 10%. So over the last 5 years, there has been 50% in terms of reduction. The baby was the America First Global Strategy, which was signed in September, and which is really changing the landscape on how emerging partners are working here in the country to help the government in terms of HIV implementation. All right, I thought I would go backward. So there is a big problem. Over the last 20 to 25 years, the US government has been funding a lot of the recipient countries. And this has led to a lot of dependency on donor. And therefore, most of the counties, even the national governments, do not allocate enough resources for HIV and TB. although the IPs have been leading the effort, of course, you have seen a lot of duplication and a lot of sometimes lack of integration with the national health systems. Like the donor, they have their own system of reporting, the DATIM, while the government has HIS, and these are really parallel systems in terms of, that was early, in terms of how we do things, but I'll be fast enough. But with the possible G2G funding, either national or county, the counties still have no enough capacity to be able to manage, especially the US donor funds, which are a little bit complex. So what we did is administer a tool called Kenya County Assessment Tool, which was developed in 2021, jointly by PEFA and the Council of Governors, and basically it looks at all the 6 pillars plus 1 of the WHO, and of course plus other things like county readiness to be able to implement HIV/TB program. So good enough that we found out the county demonstrated a very good involvement in terms of leadership and governance. These are the county assembly structures where they have an established county health committee, which actually oversees the issues around health generally, but also in addition to HIV and TB. And of course, the CHMT. So there was a scoring method. The chart on the right shows you blues, some red, and some orange. So where you see a longer blue means there's a lot of involvement of the county, and it is strong. It can take over. And where you see less, it means there's very little county involvement in that. So looking at our results, major gaps were noted in management of the grants, service delivery, which was also a problem, and some issues around logistics. There was also an issue around Kenya EMR, where the county is running a parallel Kenya EMR in its facilities. In conclusion, under leadership and governance, although we have seen the strong governance and leadership structures, there is need for stakeholders engagement meetings towards sustainability. So that was lacking, that a lot of stakeholders around, and especially also the private one, are not being onboarded to discuss the sustainability of HIV/TB program beyond the donor. Human resource, there have been low absorption of the partner-supported HRH, and therefore we recommend the county through the Public Service Board to be able to absorb this staff who are working in our health facilities into the mainstream. In terms of financing, we recommend to strengthen program-based budgeting and also to have costed HIV/TB programs or annual work plan, including improving SHA enrollment. I think the last time we checked, SHA enrollment was around 50%, so there's still quite a number of people not enrolled. And then on health information, we recommend the county to adopt a facility-wide Kenya EMR. I want to acknowledge my co-authors, Walter Kiptirim, Desmond, Richard Siengo, our county collaborators, Dr. Hassan, Maria Mola, Ben Kitole, our county government leadership, CC, Chief Officer, and USP leadership, Dr. Oyaro. Santeni.
Thank you very much for that nice presentation. Our type of you are the chin in keeping until now. Asana, thank you very much. I think our second presentation for in the room will be from 2 people from framework. Thank you. They'll present to us about HSIF versus FIF, financing quality healthcare services, the case of Kilifi County hospitals. Karibu sana.
Greetings. My name is Fred Mumba. I'll take you through. Thank you, Professor. You have done the donkey job, sorry. So I'll just go through the HSIF. I'll not go through these ones, okay? So we are talking about Health Service Improvement Fund for Kilifi County. So Kilifi is among the first counties in the country to come up with a regulation to ring fence on the health finances. And it's called, the regulation was the Kilifi County Health Service Improvement Fund, 2016. This was as a result of the hurdles that the county and the country, before devolution, had faced. HSIF borrowed heavily from an FIF policy by the national government, and the road to the enactment of the HSIF Act was a collective effort of the executive, the department, and all health stakeholders. So for the HSIF Act, there is a fund board. It's called the HSIF Fund Board, which has a chairman, a vice chairman, and members not more than 7. So the Kilifi health financing landscape before devolution. So the county government of Kilifi was relying mostly on the NIDA fund for level 2 and level 3, user fee, free maternity, NHIF, World Bank. Overview of, going back, sorry. So the main essence of enacting Health Service Improvement Fund was to ensure that there is autonomy because of the ring fencing of the health finances. So it brought about autonomy in budgeting and spending, timely payment of health service providers, improvement in revenue collection. Revenue collected improved because the money and the facility managers were aware that the money won't be remitted to the county treasury. Improvement of health products, because there is money, there is availability of, there is money, so that means the facility managers can be able to purchase health products. Improve health facility infrastructures, empowered facility managers, because if someone has money, of course, they are empowered. So the hurdles of HSIF, of a reliance of HSIF fund. But ideally, the fund was put in place to complement the county budget or the Department of Health budget. But right now, the facilities are surviving on the HSIF. Overcommitting of allocated budgets. Most of the hospitals are overcommitting their budgets because of the over-reliance, the first case, because of the over-reliance on HSIF. Lack of budget synchronization. There is no synchronization between the county, the Department of Health budget, and the budget by the HSIF board. Shrinking revenue basket. Because we are encouraging 100% transition to SHA, that means there is reduction in out-of-pocket financing for healthcare. So if we are encouraging 100% transition to SHA, and SHA is not consistent in reimbursement, that means our revenue basket will be shrinking very fast. What next? The county government of Kilifi has adopted the FIF Act with some of the changes. It's called the Kilifi Health Service Improvement Financing Bill 2024. Currently, it's I think, started to be guided second reading or third reading at the county assembly. This will replace the HSIF Act 2016. So, Danida is exiting. So, will it affect primary healthcare services? That's up for the health workers to ascertain. Do we expect an increase in scope of services offered due to the infrastructure development, Kilifi Hospital, Malindi, and Bamba? Because if there is a reduction in, there is an inconsistency or a shrinking, a reduction in revenue, or not reduction per se, but shrinking of revenue, will this be the solution to the shrinking of revenue? I don't know. Recommendation: elimination of out-of-pocket financing. because we are targeting 100% transition to SHA, we need to encourage our citizenry to embrace SHA. Encourage adoption of private insurance firm coverage in our hospitals. Most of the hospitals most of our public hospitals don't encourage private firms. So that's a big hurdle because the county government is paying around 300 million to Britam. So 300 million, if we get around 50% of it, that's around 150 million. It will be a big help for the county. Thank you, thank you. Increase in transparency in budgeting and expenditure. We need to ensure that there is inclusion of all the department heads and everyone in the hospital on how we budget and we spend. Thank you.
Yes? Yeah, better. Thank you very much, Fred, for that presentation. And I think at least we have a bit more idea what's happening on the financial side. Maybe some people just like me made pictures of the slide to really look at them later to keep up with you. But thank you very much. I think I'm informed that now for the online presentation it is ready. So sorry for that. We can welcome Dennis Mwambi for the presentation on the impact of the advocacy toolkits on health financing in 10 Kenyan counties. Karibu, Dennis, wherever you are. I am told that in the interest of time, we will get his presentation tomorrow because I think there's still something to be spoken. So I think with the ceremony in mind, we do this. Yes. So I'm still with that presentation today, but I think we had a presentation from Peter, from Fred, from Dennis, and Dr. Baraza. So I hope we kept notes and at least our questions not arisen. So please, anybody with a question, you can show your hand. We will take 1 or 2 questions only. Yes, I have one person here. Anybody else with a question? And I have one lady over there, so let me start. If it's very short, I can add you. I think I'll take all the 3 questions, and then the presenters can take note and answer after that. Yeah. And please introduce yourself.
Thank you very much. My name is Kennedy Wakoli from AMREF. I have a question to Professor Edwin's presentation. There was a unique mention of maternal health as some of the services that improved as a result of FIF. Given that facilities provide a number of unique services apart from maternal health services, the isolation of maternal health services is quite striking. So I just wanted to understand what elements of maternal health services improved, given the fact that maternal health services are primary healthcare services that are available in all facilities. So what elements of maternal health services were strikingly mentioned that improved as a result of FIF? Thank you.
Thank you very much. I think, Edwin, you have noted.
Good afternoon. My name is Dr. Shahada. I'm a pharmacist at Kilifi County Referral Hospital. So I have 2 questions, one for Professor Baraza. So if Kilifi County was to just focus on one driver in each of the 3 pathways to accelerate progress towards UHC within, say, 2 to 3 years. Which 3 should be prioritized and why? My second question goes to Mr. Fred Mumba. You're talking about 100% reducing the out-of-pocket spending for health, but how sustainable would that be, given that SHA or SHIF as it is does not currently provide for, like for example, if you're dealing with conditions like sickle cell disease, it does not refund the medication, because the refund for sickle cell disease is only limited to seeing, say, the clinicians. So how sustainable will it be when it comes to buying the medicine products, hydroxyurea and other medicinal products, or even using the lab services? Because not all services they're able to access, and that's just one of the conditions.
Thank you. I want to ask Professor Barasa two questions. The first one is, how do we remodel PSC to fit into the various funding models that you have said in Kenya? Because we already have the PCNs in place, but we are not seeing a concomitant change in terms of how we are managing health services. And then the other question is on funding for the primary healthcare facilities. You've talked about autonomy, which is a very good word to talk about for healthcare providers working in those facilities. So I always wonder, how will we detach centralization of primary healthcare from central, from being central to being at facility level, where they are able to procure, they can actually be able to have all those autonomies. Considering that Mumba has talked about something at national level people call an animal. The fund manager's office. Because at the end of the day, if a healthcare provider, the manager at the hospital will not make a decision before they pass through the fund manager, then it becomes, it is actually a good definition of lack of autonomy in management of the resources that are going to the facilities.
Asante sana. I'm not sure whether you introduced yourself.
Oh, my name is Kenneth Miriti. I coordinate the reproductive maternal child and adolescent program in the county of Kilifi. Thank you.
Thank you, Kenneth. I want to believe that I'll give Mumba first, because you got so many questions. I think I give you a little time to digest.
Okay, thank you for the question, Dr. 100% transition ain't realistic as a financial guy. It's the president who's saying he needs 100% transition. But for me, let's say 70 to 80% is realistic. That sounds good, right? So with this, that means we will be able to have a certain level of freedom, let's say 20 to 30% in terms of out-of-pocket health financing. About your second question, it was about critical care services. I think there's a critical care bill or something act which needs to be signed or already been signed by the president. Will sort out the issue of cancer patients. I stand to be guided. The cancer patient. Sour. I think I've answered your question.
Thank you very much. Dr. Barasa.
Good, thanks. So a couple of questions there. One was from Kennedy, I think from AMREF, which was around clarifying the maternal health services that improved, the specific services that improved. So the specific services that improved was ANC, PNC, and family planning. Those are the ones that I can remember. And as you can appreciate, those are actually linked. So if you're having people come to sort of incentivized facilities, to increase uptake. There was a question from Shahada. I hope I'm pronouncing your name, the pharmacist. I hope I'm pronouncing your name correctly. And this is an interesting one. If I were to pick one driver through each of the pathways, and remember there were 18 drivers across the 3 pathways. So this is my response to that. One, as part of the, what I provided as the reason policies work or not work. If you want policies to work, you have to adapt a whole system approach as opposed to singular interventions, because systems are complex and the specific interventions work to complement each other. That's one. So you shouldn't be looking to saying we just need to focus on one. However, reforms do not occur in a vacuum. You're not starting from scratch. Kilifi County was not established the other day, right? Which means that there are already ongoing reforms and interventions that are within Kilifi County. So the approach to deciding what to prioritize is mapping the 18 drivers against what's currently happening in the county and the competence of the ones that are currently happening. So for instance, the first pathway is around increasing availability, increasing flow of funds, and increasing allocation. And one of the reforms there is health facility autonomy. Kilifi County is already doing that. So it doesn't make sense to say we will do health facility autonomy. Kilifi County is already doing that. So you need to focus on what is not working very well. And even for the ones that are working, like autonomy, you need to ask yourself, what are the strengths and weaknesses of your design for autonomy? Part of what I highlighted with autonomy is this problem of providing financial autonomy and not providing autonomy for the other core functions. So you need to ask yourself as Kilifi, are your facilities, do they have autonomy over procurement of health commodities, for instance? And if they don't, then maybe that's what you need to focus on, because you're going to struggle with getting autonomy to improve availability of medicines if health facilities do not get to decide when, why, how to procure medicines. So map against the 18 and choose the ones where you're not doing well. The one that I am sure is level. Question which linked to the question to my response to the question, which is really, again, you need to let me beyond autonomy. Yes, it's autonomy of answers, but why? Why do you offer to put this about finances? For two, they are things. So you need to make sure that facilities also have some level of autonomy across their core functions. So finance, procurement, HRH, planning, and so on. Having said that, we need to understand that autonomy is not black and white. So it's not either or. It's on a scale. So when we say financial autonomy, there are grades to financial autonomy. It is quite possible to have different rights at different levels. And it's also quite possible to look at a very low facility and say, well, on their own, they're not going to be able to implement this and they need some higher level support. So autonomy is not black and white. It's about calibrating it to the capacity of that facility. I think there was a question about how do we remodel. So PCNs, the thing about PCNs, on paper, PCNs make a lot of sense. On paper, they make a lot of sense. But why? One of the things I talked about is first principles. Why do PCNs make sense? It makes sense to network facilities so that you can coordinate care and so on. But what does that actually mean in terms of first principles? For you to coordinate care, then you have to make sure that there is a relationship between the two facilities. And that relationship is not just a word. That relationship has to be financial, it has to be procurement and supply chain, it has to be human resources, it has to be information systems and so on. If you do not have those relationships between the facilities, then they are networked on paper, they are not networked in practice.
Thank you very much. And somebody's clapping, and I think you deserve a big clap. I think it's clear that even in the morning we had a speaker from Kemri, Professor Tsova, and I think you've emphasized several things that he also emphasized on the integration, on the importance of budgeting and autonomy and planning to be like together. Thank you very much. I think with that we have a small, should I say, presentation talk from the Chief of Party for USH Stawisha Pwani, Dr. Patrick Oyaro. Karibu sana, Patrick. I think the accountants among us talked about Danida exiting, and I think yours follows quite well there. He will give us a spotlight conversation on transition and sustainability of HIV and TB programming post-donor support. Karibu sana.
All right, Asante. I don't have PowerPoint presentation, but I just want to kind of summarize some of the things that have already been talked about. And I work for USAID Stawisha Pwani, led by LVCT Health in partnership with CHEB and AMREF. And I still mention USAID, yet a lot of us know that USAID does not exist. But because of our branding haijakuwa changed, so you'll still see this until 31st March 2026. That's so soon. I have a question for us. How many of us think that we could have done without donor funding when HIV was found in Kenya? How many of us think that we didn't need donor funding? Yes, I've seen a few hands. How many of us think that we needed? I guess the rest, or some of us don't know. Okay, question 2. You are diagnosed with HIV and you go to the health facility and you're told to choose whether to be served in the outpatient or go to a building called HIV clinic. Which one would you want to go to? Which one? Outpatient. Bwana Director, umesikia hiyo? So integration already, but because of the emergency nature of the condition, things had to be done pretty fast, and probably that is what led to having a siloed program in terms of systems and actually and the actual attending to patients. So this has happened for more than 20 years. As an intern at Jaramogi Oginga Odinga Hospital, we had the hospital ward full to the brim, medical ward full, patients even sleeping under the bed. Only until we started testing and diagnosing guys with HIV and stop this business of and putting them on treatment is when the workload reduced. And we saw people, we saw the hospital having fewer patients. They were no longer sleeping under the bed. So something happened. But here we are. HIV management is now mature. We have people who are living with HIV on treatment for more than 20 years. What should we do? A lot of support for HIV, TB, malaria has been through donor funding. And all of us said here that it was important to get that money. But here as Stawisha Pwani and several other programs that have been funded by US government, we have been told to do a budget called a bridge plan from October 2025 to March 31st, 2026. So on 1st April, you may not see me and several other people here. The question is the government ready to take over on 1st of April? How many feel that the government is ready? Yeah. All right. There are those who are saying the government is ready. There are those who are saying the government is not ready. We are supposed to, transition is supposed to take place. The previous speakers talked about sustainability, that as you make proposals, you need to include a sustainability plan from the beginning. If we didn't do that, then we set ourselves to fail. However, for the last few days we have seen, and Dr. Masaulo spoke about it, A few days ago, there was something that was signed, a framework that was signed by Marco Rubio and Musalia Mudavadi, that for the next 5 years, there's going to be what is called G2G, government to government funding. So currently, we have money from the donor. All right. 5 minutes, 1 minute. Okay. So there is something that has been signed, 5 year. And there's going to be a government to government kind of funding. Money will come from the donor straight to the Kenyan government, national government. Now, the mechanism through which this money will trickle down to the counties who are implementers, we don't know. Now, that is what we need to know. And the ball is in the court of the Council of Governors and the directors and the chief officer, the CEC, to find out how are you going to get that money to implement. We expected to transfer 13,000 health workers by 2028. You expected to be able to provide technical support. So that is what we are talking about, and I'm bringing it to you as a case, practical, what is happening. So from April 1st, what are we going to do? The next 90 days, you will be expected to sit down and do an implementation plan on how you're going to serve the 1.3 million. Lastly, let me say that the speakers in the morning talked about closing the tap. Prevention is the way to go. Lenacapavir is coming where you can inject twice a year, and there is prevention of HIV. But the donor can only afford 2 million vials for now. That's not enough. Are we going to harness resources domestically to be able to fill this gap? The health systems blocks have been talked about, and I think we have to make sure that we are ready during this transition and sustainability. I will stop there because I know that as we continue with the presentations, a lot of these things are going to come up. And if you have any questions, we are going to be available between now and end of tomorrow, and we can continue with this discussion. Just lastly, community health strategy has been talked about, and that is where prevention is. I have been involved in 3 studies where using community health strategy, CHPs were able to diagnose even TB spine in the community. CHPs were able to use IMCI, and in that study they did better than nurses. Last one we participated in where CHPs were able to make sure skill delivery happened from 60% to 90%. Let us use the community health strategy. I've talked a lot about HIV, and for TB, imagine Oyaro traveling in a bus from Kisumu to Kilifi, and Oyaro has multi-drug resistant TB, and Oyaro is coughing, and it is cold at night, and the bus window is closed. And Oyaro reaches here and it goes to a hospital, and that is when you're going to diagnose TB. We can do better. Thank you.
Thank you very much, Patrick, for that inspiring talk. And I think at least he has not only told us that we have to find other sources of funding, but he has also told us we should make sure that what we need is way less. So thank you very much. I appreciate all the people who have presented in this session. And I would like to hand over my session to the next moderator, who is Christopher Maero. I know on your program it says there's a health break, but I think for the sake of time, we will proceed with the next session. Karibu, Christopher.
A better round of applause. Thank you very much. So mine will be quick. We have 30 minutes for this next bit of work. And so it's a quick panel discussion. It's about a study that the African Population and Health Research Center has been doing in Kilifi. And I would like to quickly invite the panelists onto the stage. And even as they come up, we'll have a quick highlight of this study. what has it been about? What is coming out so far? What is the spotlight, for lack of a better word, of what is coming out of this study? And to give us that quick presentation, it's none other than my colleague, Ramatru Wadrogo. Let's give her a quick clap as she comes up. Yeah, this side. No, just here. Okay.
I have a presentation. Yes. Thank you so much, Christopher, and good evening. Good afternoon, everyone. I think I'm already in the evening. I'm really pleased to make this presentation where we will be presenting the baseline findings for an implementation research that APHRC is undertaking in the Kilifi County jointly with, sorry. Here? Ah, okay. Why is it not going back? Sorry. Yes. So an implementation research we've been implementing jointly with the county and other partners, aimed at improving quality of post-rape and post-abortion care in the county, following other studies, baseline study that we did in the county from 2021. So the implementation research I'm talking about is aiming at transforming providers' attitudes towards provision of quality and respectful PRC and PAC services, and at the same time improving also adolescent girl and young women care-seeking behaviors when they are facing such kind of unfortunate event. And the intervention is about co-creating, we've co-created curriculums and messages, curriculum for providers and also messages for them. And then we are currently undertaking the implementation through a mentorship approach, and some of the mentors and mentees are present in this room. We are also holding at the same time health talks at the community level to improve the care-seeking behavior that I mentioned, plus the messaging. So as I said, we are presenting the baseline findings that was conducted around June and July. And just showing how we did the analysis, so I will be presenting on the signal function of PAC in the health facilities, post-abortion care. And when I'm talking about basic PAC signal function, it's about these variables that were analyzed to get to the basic PAC indicators. And the comprehensive is all the above plus what is added. I'm trying to go fast so that we catch up with time. So from the survey we did in all the primary healthcare facilities, in all the healthcare facilities in the county, including private ones, what came out is a weak capacity of the health facilities, especially the primary one, to offer basic post-abortion care. And you can see the rate here at 8.5%, which is far below the national rate that is about at 18, if I'm not wrong. And these are the drivers of the low capacity, meaning the low capacity of facilities to provide family planning contraceptive services, the ability also to remove retained product of conception, and sometimes it's that inability to remove the retained product of conception is due to lack of equipment, due to lack of supply, making the providers unable to do it, and also having a providers who are trained to be able to offer such services. And if you take by sub-county, we can see that only Kilifi South and Magarini sub-county have at least 29 to 39% of primary health facility being able to offer such services. If I go to the referral level facilities for comprehensive PAC, it increases, but overall it's about 31, but let's say 32% of them able to offer services. And still the reason is around inability to provide blood transfusion, which is not only the case for PAC patient because it also affects other type of patient needing such services. And also the inability to offer surgical capacities. So if you look at by sub-counties, it's mainly Kilifi North who has more than 44% of the level 4 capable of offering all the package together. So this is the different aspect I was mentioning earlier. So all that together affect the patient experiences, because when they go to the health facilities, they are likely not to be able to access those services, and these are some of the indicators we found. The main one being the long waiting time, because, okay. So the key messages from here is the low capacity to offer, meaning that patients who first visit the primary health care facilities are likely to be referred to the high-level ones. And then when they get there, it leads to some overcrowding because those facilities already have many patients to handle, and also leading to them delaying accessing care. And when they get there with a very bad condition that require life-saving procedures, there is issue around blood transfusion and capacity to perform some surgery that also affect the likelihood to receive the care they need, leading to poor patient experiences. So this was, as I say, to set the scene for the conversation with the panel. Thank you so much.
Thank you. Thank you very much. Let's clap for her. And so we won't let Ramatu go. She'll just have a seat somewhere here. I wish this podium wasn't here, but we'll work with what you have. We'll just have some quick questions, sort of to try and interact with these findings. We'll have more chance to interact with them on 18th, but just a quick overview and some quick questions. And I would like to, it's a quick panel discussion. So the very first panelist I would like to call up is Dr. Hassan Leli. Kindly come up, and you can clap for them as they come up. And then Dr. Miriti. Yes, let's clap for him. And then Dr. Mitei. Dr. Mitei Chepkoni. Aha, yeah. So, yeah, right here because of that podium. We can quickly get into this. And so, and I would like to start from, I'm sure the profiles will be given more in-depth. Probably we've interacted with a couple of the panelists that you see here. We'll get their profiles more as we move along. So, Dr. Mitei, I would like to start with you. Thank you for finding time to join us today. So, you've had, I'm sure you've interacted with the study, and quickly, how do some of these gaps that you're seeing coming out, especially facility and supply, affect providers' day-to-day experience and ability to provide compassionate and quality services? And what innovations do you currently use as providers to overcome some of these gaps that have been highlighted?
Those are very heavy questions. Very heavy but pertinent questions. My name is Dr. Mitei Chepkoni. I'm an obstetrician gynecologist working in Kilifi County. I love pediatrics and adolescent gynecology so much. So today I've really been pleased to listen to a lot of presentations around that. But I'm also an advocate of women's reproductive health, and probably why I'm seated on this space, because I like to speak for both mothers and the babies. So yeah, as an OBGYN working in Kilifi County, the facility and supply gap shape a lot of our day-to-day experience and ultimately influence the type of care that we give. When essential commodities like MVA kits, misoprostol, analgesics, antibiotic, functional examination lights, or basic infection prevention supplies are inconsistent, it creates delays in care and forces us to improvise in ways that should not be necessary in a modern health system. It also affects the emotional experience of providers. I'm sure many of you speak of that. When you have to tell the patient, nyamaza niko karibu kumaliza, and you're not giving painkiller, or you didn't have misoprostol the mifeprostol to ripen the cervix before conducting an MVA operation, you can imagine that normally causes a dent, even for the provider. So it affects that, and also you want to work while offering dignified and compassionate care, but when the tools you need aren't available, you constantly feel like you're stretching beyond what's safe or ideal. Now, you've asked about what are the ways that we've improvised this. I'll begin by, first of all, saying we are able to communicate within ourselves across cadres above and below, and it's either through simple phone calls or WhatsApp groups, and like Rama alluded to, we are having some mentors and mentees amongst us, and we've been trying to actually teach and mentor them. Of course, they have their own fears because there's a lot of conversation about abortion that makes even healthcare workers become a bit skeptical. And I think one of the cases that was very loud on TV affected someone from our county. So there's that, but we are able to share that knowledge across, below. Like we said, the knowledge does not always come from above to below. It can also go from below to above. The other things is good neighborliness within the facilities in Kilifi County. So for example, if I do not have misoprostol in Twapa, I can easily tell Busra, please, when the ambulance comes to pick our blood, could you please give misoprostol? So that I would say is a good neighborliness within the facilities. And of course, strong teamwork and task sharing. The fact that I'm a gynecologist does not mean I will not let a nurse learn how to do MVA procedure or how to take care of a patient who's come and has been raped. It's not always the person who is the senior most or who has the experience that will be found in the facility. However, if as a lead, you've actually taught people who work with you and you're a team, that patient can still be handled by anyone the patient meets. And then I'll say the obvious ones that probably everyone will relate to. Our patients, I think there was something about patients feel delayed and there is lack of privacy and confidentiality. The things we've tried to do innovatively, and you can all relate, is sometimes we make the barriers ourselves. Tunakuwa screen. Uongo ama ukweli? Yes, or sometimes we use the screens in our wards to create a space where you can actually do the procedure if you lack a room that offers that. So I would say that. And of course now involving the community that they can come and there's a desk specifically to be able to deal especially with gender-based violence or rape cases. Thank you.
Thank you. Thank you very much, Dr. Mitei. And you raised some interesting insights on the capacity and the resources that we have at the county. I would like to direct the next question to Dr. Hassan. Listening to some of these insights, I'm sure the county is already working on quite a number of them. And listening to some of these gaps, so what is the most urgent gap that you feel Kilifi must address to improve either post-abortion care or post-rape care service delivery or all those kinds of services at the county level?
Thank you. There are quite a number listed, but I would say, importantly, looking at improving service delivery and training for the providers. Service delivery, this involves, one, ensuring availability of commodities, also strengthening the referral system, and ensuring commodities also something like the post-exposure prophylaxis and emergency contraceptives. So the challenge has been, especially when it comes to commodities, we procure from KEMSA as the primary distributor to the public facilities. The challenge of the fill rate not achieving 100% placed by our orders. Another thing, of course, we incur debts. So the issue of when I've supplied, you have not paid me, puts us in that quagmire. Though I'd like to go to a point that was raised by the previous speaker, that is Professor Baraza, in terms of financial autonomy. Facilities also collect funds. So that the challenge has been also to make sure they are also budgeting into into health commodities. So one of the things that we had done in terms of financial autonomy was also impose a budgetary allocation of the funds collected into health products to make sure, because the essence of facility improvement funding is to make sure there's the funds that you collect improve facility. Of course, the disbursements have not been as smooth as possible, so the funds that are collected are not at the point available to make sure there is that turnaround. But in terms of improving service delivery as well, we have been incorporating plans. Like, for example, we have the Every Woman, Every Newborn, Everywhere plan that we've incorporated post-abortal care training, post-rape care training. Also, we have partnerships with Prompt, that is with M-Pesa Foundation and AMREF. We're implementing the Uzazi Salama. As you can see, Kilifi South and Magarini and all the sub-counties that I mentioned are doing well. And that is a result of that intervention and that partnership, which allowed us now to expand further. So we're expanding to the remaining 5 other sub-counties. So I'm hoping with these partnerships, and the partnerships, aside from training, we are also helping us procure as well, additionally, for the MVA kits. So we are looking to have additional improvement. Another very important thing here, you mentioned about blood availability. Our blood donation, or blood giving habits. Of course, like last year, we had we collected 6,400 units, but we aim to move that to almost to 8,900. But that will come from us being able to be willing to give. Because right now we impose a replacement scheme. That is, if I have a patient, I have to make sure the relatives also donate to make sure that we give and cover for the next person. Aside from that, of course, the screening is something that is still centralized. It's not done by us counties. So we've had instances of reagent stockouts at the transition center. So as we've collected blood, but we can't use it because the results are pending. But another important thing also is the feedback, because we've seen issues where the clients are raising, they're not comfortable with some things I've seen here from the study. So the other thing is to improve feedback. We're implementing a program. We'll be doing with Jacaranda, and also we're doing that with Uzazi Salama, where we'll be having prompt feedback digitally. So it allows us to also take quick action and respond back, because the essence of feedback and communicating that feedback is to make sure the client has confidence to come back again and to raise the trust in us. So that the feedback and prompt response will allow us to make sure that anything that is picked up we respond to, and we take care of those complaints or anything negative that may interfere their treatment.
Okay, thank you very much, Dr. Hassan, for that. And good that you've started mentioning about partnerships and how useful they can be to the county. I have a quick question for Dr. Miriti. So, what partnerships do you feel can immediately support or fill in some of these gaps that you're seeing coming out today?
Thank you, Chris. I'm not a doctor. I'm a prospecting doctor. I'm a doctoral student, so thank you very much for graduating me before I'm conferred. Yeah, thank you. So, Kilifi County, since 2019, I talk of 2019 because 2018-19, that's when we left, actually 2020-21, sorry, not 2019, is when Afya Pwani and the THS program ended. So, and the question that was asked by the Chief of Party for Stawisha, I raised my hand because I know that after that we were able to survive. And so survival has not been easy. It has been as a result of partnerships. We have had various partnerships, including the partnership with the APHRC from 2021 on issues of abortion. I know it was a hard thing. Dr. Ramatu stuck here because we stuck with her. It was something very hard for us to be able to swallow. And so, what are we doing in partnerships? One of the things that we are doing in partnership is leveraging on resources that we have from various other partners. Dr. has mentioned about Uzazi Salama, and so many of the partners have been asking us, why do you talk about Uzazi Salama as if the rest of us are not there? And I say Uzazi Salama is actually a average program by M-Pesa Foundation and of course being implemented by AMREF, that we use the resources to harness what is already there. So when we talk about it, we are not actually marketing it. We're actually saying that you can actually leverage on this to be able to achieve various indicators in, that we are working with as partners. And then the other one is we plan to get, we have created a culture of planning together. And that's something that we need as partners who are here, and even the prospecting ones. You need to understand that for us, what we have seen work is where you work with the county health management team in the initial stages of your development of programs. So if you don't do that, then what we see is siloing of implementation of various interventions, and that leads to lack of achievement of both county and also partner deliverables. Breaking the silos, I think I've mentioned that, and then we have the strategies. This county lives on strategies. We have various strategies that we have come up with, some of them that have been even borrowed by the national level to be able to implement activities. So we always encourage partnerships in terms of looking at what is there in our strategies and implementing the strategies that we have. And the other one, the last one, is working with others in capital letters. Others are others that, since in the morning, people have been talking about non-health factors to talk about issues. For example, you know, I always tell people that post-abortion care is actually a community issue. Post-rape care is also a community issue. Actually, health takes only 30% of the response for, and actually of even prevention of post-rape care. So we work with others. We work with the rest of the community, I mean the departments, of government departments and communities, to ensure that we actually leverage on that and achieve what we need to achieve in terms of reduction of these two areas.
Thank you. Thank you very much, Dr. Miriti. Now, finally, Ramatu, you have, yeah, Dr. Miriti, I have. So, Ramatu, you've interacted with these findings. What is that quick takeaway or quick recommendation or highlight you'd give as we wrap this up?
Thank you, Chris and Miriti. You can't run away from the doctor. So we can even add professor to it. So for me, as I said at the beginning when I was doing the presentation, we are currently testing an approach called the Nisaidio Siniduru intervention to improve the quality of those key SRHR services, I mean post-abortion and post-rape care, through the training of the provider, the mentorship. And the idea is to have evidence around low-cost effective approach of training providers, because so far the training has been a costly thing, and we are in an environment where nowadays where getting funding has become challenging, so we have to innovate. So our aim is to use this testing to innovate on something, show that something can work with low resources. But for us to achieve that, we need the providers who are being trained need all what is needed to practice the skill they are getting, meaning equipment, meaning supplies. So if the county, my call to action is for the county, my request is really for the county to try and sort those gaps of supply and equipment as we work together on the training part, so that we are able to show that something is working and can be scaled up in the entire county and even other counties in Kenya. So that's my takeaway and call to action. Thanks.
Yeah, thank you. Thank you very much, Dr. Ramatu. I think we are out of time. I really appreciate the panelists. Let's give a clap to them as they take their seats. Yes, so that has been a quick week one, really just trying to see how has the evidence been translated into intervention at the county level, and really a rallying call to the county to see how can we see that some of the guidelines coming out, some of the policies are really hinged on some of this evidence that you're seeing coming out in the gaps. I've been your host for that very short session, Christopher Maero. I'm looking forward to engaging you more in future. Thank you. That has been my time. Back to you, Chair.
A better clap to the panelists, tafadhali. Thank you very much, and also for keeping it under time. Though I know some of you are actually literally dashing to the airport now. Thank you very much for those insights. I want to bring the first day to a close today. But I want to make very, very important announcements that are concerning tomorrow's presentations. So if you walk with me, we are going to do this very quickly. Day 2 tomorrow starts at exactly 8:30. So at exactly 8:30, please let us be seated in the auditorium. We can kick off the day. We are going to start off with the partners plenary session, as is on your program, which you can either scan or otherwise. Then you're going to do that for 45 minutes only. 45 minutes only. I know we've given ourselves an hour there, but we'll do 45 minutes. So if it can be short and succinct and to the point, like the one that we've had here, we'll be very, very encouraged. So let us do that for 45 minutes. And then after that, we'll have Zablon from Aga Khan University present on mastering AI. Today we started to touch on something around AI, so that will be done immediately. So that 1 hour, it will be 45 minutes, and Zablon will come in for 15. After which, we will then do a plenary session. We'll do plenary session 4. Plenary session 4 on primary health care, experiences in operationalization of PHC networks. So that will be in plenary. And then, so this is where I need you to note, and note very keenly, especially the chairs, is that plenary session 3 that was supposed to be today and plenary session 4 tomorrow will happen between 11 and lunchtime, but it will happen in parallel. So the next room in the other building will take up plenary session 5. The next room on the other side will take up plenary session 5. And then plenary session 3 will be in this room. Plenary session 5 is on communicable and uncommunicable diseases, chaired by Catherine Munyoki and Abednego Kioko, rapporteured by Walter Kagohu. You'll be in the other complex. Plenary session 3 will be here. It will be at 11. Please, the presenters also take note. Chaired by Dr. Nancy Kagwanja, Chimwaga Mwamuye, and rapporteured by Dr. Priscilla Kashero. Those are the very key changes. After that, we'll have clawed back on all the time that we might have been lost on the first day, and we will then recover after the afternoon and swiftly go into the rest of the program. Thank you very much. Please take note of those changes, and I wish you all the best. And a big clap to all of you for the first day. Right now, the posters are still out here. The tea is being served, and so are the exhibitions. Please feel free to network, interact, or otherwise. Karibuni sana. Asante. See you tomorrow at exactly 8:30. We will kick off.